Good morning and welcome everyone to the first meeting on the Joint Interim Standing Committee on Health and Human Services for the 2023-2024 interim. Let us proceed with calling roll first. Madam Secretary, please proceed to call the roll.
Senator Nguyen, Senator Titus, Assemblywoman Brown-May,
Here.
Assemblyman Gray,
Here.
Assemblyman Hibbets,
Here.
Assemblyman Nguyen, Vice Chair Orentlicker,
Here.
Chair Dunyate.
And I am here. When is that up there yet, right? Okay. And please mark Assemblyman Nguyen excused for now. He is running a few minutes late, so when he arrives, we can mark him present. Great, thank you so much. Welcome everyone to the first meeting for the Joint Interim HHS Committee. We do have a lot of items here today, and it's great to see everyone and be back ever since the legislative session closed. I want to just go over a few housekeeping announcements. Before we begin, I want to make sure that folks understand that first and foremost, I'd like to remind everyone to please silence all electronic devices throughout the duration of today's meeting. For those of you who are joining online, please mute your microphone when you are not speaking, but you can leave your camera on. Additionally, I do ask the presenters on Zoom to please leave your cameras off and microphones muted until I call up on the agenda item under which you are present. And the Zoom video call has a chat feature. However, this feature is only to be used for technical assistance. As a reminder, agenda items may be taken off on a different order than listed, and the committee's meeting materials can be found on the Nevada Legislature's website, and you can also sign up for electronic notifications related to any activity on the committee's website. Today we do have a few agenda items, and we do have the opportunity for folks to come up forward during public comment. So if you wish to testify in person, you can please sign in at the table by the door and leave your business card so that we can call you in case if we need anything. And if you do not wish to testify, you could also sign in just in case if we need to reach out to you after this meeting. And when testifying in person, please remember to turn your microphones on to speak and off to listen, because we do have others listening both here in Las Vegas and in Carson City. So first agenda item, I would like the opportunity to go ahead and have the committee members introduce themselves, and of course for our staff, just so that everyone knows who's present. So we do have an order of folks that we would like to go. So for the committee members, if you can just go over your district that you represent, your background or interest in HHS, and then because it is the morning, to make it a little bit fun, your favorite breakfast item. So. We'll start with Vice Chair Orentlicker.
Thank you, Chair. And I am David Orentlicker. I represent Assembly District 20 on the southeast side of Las Vegas. If you're standing on Maryland Parkway with UNLV at your back, my district is you're facing my district. I'm in my second term. I also teach at UNLV, so it's convenient to be right next door. I teach health law and constitutional law. My background's in medicine and law, so that fortunately this committee converges very nicely with my academic interests. And I always try to start the day with some grapefruit.
Thank you so much, Vice Chair. Senator Nguyen.
Hello, my name is Rochelle Nguyen. I represent Senate District 3, which is one of the weirdestly shaped districts. But I encompass most of the medical district down at Charleston and Rancho in that area, but I also incorporate a lot of the other medical areas around Mountain View Hospital in that area. So I follow Rancho all the way up to Ann Road now as a part of my Senate district, and I extend almost into Summerlin off of Charleston and Sahara all the way up to Cimarron. So I have a pretty expansive district. My favorite breakfast item is probably chilaquiles.
That's awesome. Senator Titus.
Good morning, everybody, and good morning in Las Vegas. I am Robin Titus. I represent Senate District 17, which is all of Douglas County, Lyon County, Churchill County, Esmeralda County, Mineral County, and Nye County, but just Tonopah and Nye County. I am a family practice doctor. This is my 5th session. I've been on this interim committee multiple times, and I've always sat on an HHS committee during session. I'm still a practicing physician, long-term care medical director. I'm the county health officer in Lyon County, and I'm passionate about healthcare, as many know. My favorite breakfast, however, is not very healthy, but I'm still passionate about it. It's Marionberry pie.
We'll take it. Let's go with Assemblywoman Brown May.
Thank you, Chair. My name is Tracy Brown May. I represent Assembly District 42, which is half of Chinatown, Koreatown, all of Spring Valley, and it goes as far south as the 215. I have the IKEA, which is very interesting. I'm honored to be here as part of this committee. I have often testified in front of the Health and Human Services Interim Committee, but have never served, and so I'm thrilled to be here. My day job is as a disability advocate, so I've spent the last 20 years supporting people who have high medical needs. I presented it to this committee in the regular session on multiple occasions, which is probably how I got here. And I would have to say my favorite breakfast item is also not very healthy. It would be cold pizza.
Awesome. Let's go to Assemblyman Gray.
Thank you, Assemblywoman Brown May, for stealing my favorite breakfast food. Assemblyman Ken Gray, Assembly District 39, Central Lyon Corridor, as well as all of Douglas County. My background, 26 years in the Air Force, and I served as everything from a flight medic, ground combat medic, to ER nurse, to a healthcare administrator, and this is my first term and loving it.
Thank you so much, and Assemblyman Hibbets.
Thank you, Chair. My name is Brian Hibbets. I'm the representative for Assembly District 13, which is in the northwest part of Las Vegas, Centennial Hills, Sky Canyon area, Durango and 95, if you're familiar with the area. I serve on HHS in the session. This is my freshman session, and I'm still learning everything that's going on. My district has absolutely 0 hospitals in it, which I would like to change. There is a standalone ER, but no actual hospitals. And although I can throw a rock and hit one for my district, it's not actually in it. And my favorite breakfast food is bacon and eggs.
Thank you so much. And then when Assemblyman Nguyen comes here, we'll have him the opportunity to answer those questions as well. I'm State Senator Fabian Danyate. I'm very honored to serve as the chair for this joint interim committee. This is my second interim session. I've served in two legislative sessions. I was elected in 2022. My professional background is I do have a background in public health. Day to day, I'm a healthcare administrator. And so I'm very passionate about this subject interest and very honored to be here, of course. I also want to just take a quick moment just to showcase a lot of the work that we'll be talking about during this interim. My philosophy is pretty simple. I try to make sure that every presentation and everything that we talk about is solutions oriented. I don't want us to talk about the problems and why the problems persist. I think we should spend most of our time talking about how we can fix them and not having to be repetitive over and over again. I also want to make sure that the success of this committee is not measured by the number of presentations that we have or the discussions that we have. I want to make sure that every bill that gets passed out of this committee is bipartisan and that those bills can come to fruition when we go up in session in 2025. I think we have an obligation to protect and serve the people of this state based on their health and their well-being. And so we have a lot of items that we'll be discussing. The main 4 priority areas that we have decided for this interim are access to healthcare, behavioral health, public health, and workforce and infrastructure. As you may know, there are a lot of subject contents that we can tackle in this committee, but we only have a short amount of time, and those are probably the pressing needs. And so we'll have discussions later today on what all of that means for our state. But that's essentially what I hope to accomplish during this moment, and of course through my service here as a chair. And for my breakfast item, I'm always a big fan of maple glazed donuts. That's the key to my heart. So next, I would like to go ahead and have the committee staff also introduce themselves. We'll start with the staff members both in Carson City and here in Las Vegas. So let's start with Ms. Kimbra Ellsworth, who is a senior program analyst.
Hi, I'm trying to turn my video on and there we are. Good morning. Thank you for the introduction. My name is Kimbra Ellsworth. I'm with the Fiscal Analysis Division of LCB, and I will be going into my fourth legislative session for 2025. And for the last two, I have carried some of the HHS accounts, and I just stand by ready to answer any budget-related questions or do any follow-up as needed to the committee. Thank you.
And favorite breakfast item?
Oh goodness, I would have to say egg in a basket.
Good choice, good choice. Let's go to Mr. Robbins.
Eric Robbins, LCB Legal. I've been with the LCB since 2012, and I've been with this committee since my first interim was the 2013-2014 interim. And my favorite breakfast item would be a nice big breakfast burrito smothered in spicy pork green chili.
Thank you so much. Mr. McDonald.
Yes, thank you, Chair. My name is Aaron MacDonald. I am the Principal Deputy Counsel for the Legislative Counsel Bureau in the Legal Division. This is my first year here. I did spend the last 12 years of my legal career at the Legal Aid Center of Southern Nevada. I was the lead attorney of the Housing Justice Program there. And my favorite breakfast item would also be a breakfast burrito, so something with legal division and breakfast burritos, but I enjoy that as well.
Thank you so much. Mr. Jeff Colomay, he is in Carson City.
Thank you, Chair. My name is Jeff Coulomay from the Legal Division. I came to the Bureau a little over 3.5 years ago out of civil practice in Reno. During the last session, I was involved with helping staff a committee in a different subject area, but I've worked closely with my colleague, Mr. Robbins, on some things in this area as well, and I look forward to being useful to this committee during this interim. I'm surprised that no one has said what I think is the most obvious breakfast item, which is coffee. That is always my favorite and is important. Thank you.
Thank you so much, sir. Mr. Ashton.
Thank you, Chair. My name is Patrick Ashton, and I'm a policy analyst with the Research Division of the Legislative Counsel Bureau. I think this is my fourth interim, and during the interim and the session, I usually staff health-related committees. A bit about my background. I'm a licensed social worker and also have a master's degree in political science. And it is my favorite breakfast item, well, coffee for sure, and then also gallo pinto with fried eggs, sunny side up. So thank you, Chair, and the committee members. I'm really happy to be your committee analyst this session at Interim.
Thank you so much. And last but not least, Mr. Florence.
Thank you, Chair. My name is Davis Florence with LCB Research. I have been with the LCB for a little over a year now, and this is my first time serving on the interim committee. And Mr. Colmay stole my answer, but my favorite item is also coffee. Thank you.
Thank you so much. Additionally, we do receive assistance from our committee secretary, Sarah Baker, as well as staff from BPS and General Services, and so I just want to thank all of them for all the work that they do. With that, let's go on to our first agenda item, public comment. If you would like to go ahead and provide public comment for this committee meeting, please feel free to come forward. The allocated time for this is 10 minutes. Public comment will be limited to 2 minutes per speaker, and in addition to testifying in person, members of the public may provide public comment in various other ways. So if you guys want to come forward, looks like we may go over 10 minutes, which is good. So if we go over it, it's fine. But just
Mr. Chair.
Forward, same thing in Carson City.
Before
Yes,
we
ma'am.
take any public testimony, perhaps we could introduce our member that has just arrived.
Assemblyman Nguyen, if you can provide your brief background, your interest in HHS, and your favorite breakfast item before we.
Thank you, Mr. Chair. Good morning, everyone. Apologies for my tardiness. I'm not used to the commute, but it's been a minute, so nice to be back here. Great to see everyone. My name is Yui Nguyen. I have the honor to represent Assembly District 8 in Southwest Las Vegas. It's the most diverse district in the state, I think, with 40% of Asian American, Native Hawaiian, Pacific Islanders. So very proud to say that statistic over and over again. My background has been about direct service and working with our immigrant and underserved communities, and I've been doing that for over 20 years. Trying to catch my breath because, it's running a little behind. And, one of the things that I experienced as a parent when my firstborn, came out about 11 years ago and has so much issue, in the first couple of weeks of his life. And I had to learn the hard way how to be not only a parent, but a caregiver, as well as ensuring that the kid's going to stay alive. And I thought I was educated, but boy, was I wrong. And learn a lot in terms of navigating the healthcare system. So it really ignited a passion of mine to be more involved in the healthcare space and ensuring that doesn't matter who you are and your background and whether you know or you don't know, that you can come together and make sure that everyone thrive and do well. So, favorite breakfast? I would just say coffee, because that's something that I need to have every morning. I am not a morning person. I think that is public knowledge. So thank you, Senator Titus, for reminding a lot of me today. So I'm going to rely on her guidance for the rest of this meeting. Thank you, Mr. Chair.
Thank you so much. All right, let's go ahead and begin with public comment. We'll start in Las Vegas, and I'm not sure if there's anyone in Carson City, but if folks can come forward, and then we can begin. We'll start to the left, in this case.
Thank you, Chair Dunyate and members of the committee. My name is Leah Case. I'm here today representing the Nevada Psychiatric Association. In regards to Regulation R059-23P, we have had the opportunity to speak with the Board of Pharmacy on this regulation. It was up for discussion at the Legislative Commission on January 10th, and that meeting was canceled due to weather. So the letter that I've submitted and was checking with staff to see if it was posted yet, it was also emailed to all of you, is dated January 10th for the Legislative Commission, but the recommendations remain the same. That's all in there. I really wanted to focus my public comment this morning on, we have a group of providers, a group of physicians in this state who have the specialized training in addiction medicine, in addiction psychiatry, and the way this regulation reads, it highlights a discrepancy in the way we treat these various prescribers. So in Nevada, we have APRNs, physician's assistants, and physicians who have traditionally been the prescribers of medications, the diagnosticians, the folks who you go to see and you say, this is how I'm feeling. They give you the diagnosis, and then you go and get your medications. And the legislature, in turn, has said, this is what we require of you as a prescriber, to be able to work with the public, to keep the public safe. Assembly Bill 156 passed last session, and in Section 12.3, it states that the Board of Pharmacy must come up with these protocols. That is a deviation from past practice in the legislature, where you, as a legislative body, have specifically designated what these guidelines and protocols need to be for other prescribers. So we're seeing this deviation in prescriber types and the requirements for each. And it's sending a message through the psychiatric community that you are not the prescribers we want in Nevada. You are not the diagnosticians we want in Nevada. You are treated differently in Nevada. And they have this expertise, they have this training. We know that they're competent. They've been doing this for years, for decades. And now we have a discrepancy in how we're going to treat this particular patient population of folks with addictions, folks who are struggling with opioid use disorders. So there are recommendations in the letter that we've submitted. It's a joint letter from the Nevada State Medical Association.
Ms. Case, if you can please wrap up your comments.
Absolutely, and please refer it back with guidance to increase the protocols. Thank you.
Hello, my name is Zach Roscoe, and I'm here on behalf of the Nevada Pharmacy Alliance. I'm also a licensed pharmacist in Nevada, and I'm here to support the Regulation 059-23 from Assembly Bill 156. I wanted to just give a brief example of the safety and efficacy and expanded access that might be seen with the implementation of these regulations. While I live here in Nevada, I do work remotely into Idaho for Idaho State University as the director for the Center for the Advancement of Pharmacy Practice and Research. And in July of 2023, restrictions on pharmacists in the state of Idaho were lifted to allow pharmacists to independently prescribe controlled substances, including medications for opioid use disorder. I just want to give a firsthand account of a community pharmacy I'm familiar with in rural Idaho that recognized the need of their patient population where there was limited access with the licensed and trained physicians and other healthcare providers. The pharmacist started offering medications for opioid use disorder treatment within their community pharmacy and has taken up a panel of about 60 to 80 patients they see on a regular basis. Beyond tracking safety and efficacy of this treatment, they also assessed the patient's other healthcare needs and found that while these patients were engaging in opioid use treatment at other providers previously and could not continue with them for various reasons, they never were encouraged to engage in primary care or other healthcare services. The pharmacy team screened the patient for other needs and through partnerships with community providers was able to connect about 70% of the patients with primary care for the first time. So I just wanted to give an example of what this could look like with similar regulations in place. Thank you.
Hi, thank you, Chair and committee members. My name is Crystal Riccio, for the record. I am a licensed pharmacist here in Nevada, and I practice in at Behavioral Health, which is an addiction treatment center here in Nevada. I'm a pharmacist. I applaud the session last year for passing AB 156. I feel like it meets a critical need. We have 2 people dying each day, one person dying every 8 minutes from a fentanyl overdose or poisoning in this country. It was an all-hands-on-deck bill, and I believe that it's going to meet the needs of our community. You mentioned public access, behavioral health, access to healthcare being your priorities of this committee, and I believe that this bill and this regulation really do answer that. I feel like this is going to be an all-hands-on-deck priority for our state and our country, and I feel like the session answered that, and I feel like Regulation 059-23 is in response to this crisis. Thank you.
Good morning. My name is Penny Eccles, and I'm here today with Act for Kids Nevada as a parent of children with special medical needs. I would like to comment on agenda item number 10, discussion of topics related to HHS future consideration and meeting topics. I ask that you consider a robust discussion to access to pediatric subspecialty care in Nevada and work to identify ways to improve access to comprehensive care. For our family, the burden of travel out of state for medical care has been heavy. In August of 2022, one of my daughters suffered a concussion at soccer practice and was set to resume activity when she was concussed again in October. However, this time the seizures and pain that resulted from that second concussion required emergency room care, and she spent 3 days with constant non-epileptic seizures and pain that did not respond to medication, and we waited 72 hours for a psychiatrist to visit her in the PICU to help us prescribe a plan of action. My husband advocated for an ICU to ICU transfer, and she was sent to the neurotrauma unit of Primary Children's Hospital in Salt Lake City. Once my daughter had access to providers who understood her condition, she was able to come home and heal with a new understanding of the interplay between mind and body. During school breaks, we travel for specialized physical and occupational therapy and for treatment of chronic migraines resulting from her post-concussion syndrome diagnosis. Our insurance covers the cost of office visit, but not our travel costs. And no one can reimburse me or my husband for the cost of separation from family, bedtime hugs missed, family meals spent in different states, my daughter's exhaustion from traveling during a migraine episode, missed hours of school, foregone recreational activities, and the ghosts of trauma that haunt us every time we have to share her medical history with a new provider, because hospitals and primary care physicians and specialties they don't have access to each other's records. I asked the committee to consider changes that we need in Nevada to access that comprehensive pediatric care. I ask you to work towards solutions, including a freestanding nonprofit children's hospital, an improved provider pipeline for my family and thousands more who need the care that is close to home. Thank you again for your attention to this topic and the opportunity to share my story. I appreciate your dedication to the idea that home means Nevada, and I encourage us all to consider how we can improve our home to take care of our sickest children. Thank you.
Good morning. My name is Patrick Kelly. I'm the CEO of the Nevada Hospital Association. I'd like to begin with a thank you. In the last legislative session, you appropriated $20 million for nursing programs in the state. It was much needed money to support, improve, and expand our nursing programs. We hope that you'll consider a larger appropriation in the next budget if you determine that the money was well spent. Workforce continues to be a huge challenge for healthcare providers, and nursing remains at the top of the list. Hospitals alone have more than 2,000 open RN positions. Other healthcare providers, such as nursing homes, public health departments, and others, have significant openings too. The nursing shortage creates a bottleneck in Nevada's healthcare delivery system. Hospitals are unable to discharge patients who are medically cleared for discharge because other providers are limited in the number of patients they can admit to their facilities because of staffing shortages. On average, the hospitals are currently holding hundreds of patients a day who are medically cleared for discharge. This is concerning for three reasons. First, the equivalent of one large hospital is taken out of the state's healthcare delivery system. If a major catastrophic event occurred, hospitals would be in short supply, hospital beds. Second, we don't have rooms for patients who need to be admitted. I'm sure you've heard stories of patients waiting in the ER for a bed to become available. Third, housing patients in the hospital is not good for the patients. Hospitals are built, designed, and staffed for short-term stays. Patients need to be moved quickly to an appropriate level of care so that they can receive needed services such as physical therapy, occupational therapy, and speech therapy. Patients also need to be in an environment that promotes socialization and activities that stimulate their brains. Without these, atrophy can set in. Behavioral health is another area of concern. Many law enforcement agencies and first responders transport patients with mental health problems to the emergency department. EDs are not a good environment for people experiencing a mental crisis. EDs are noisy and extremely busy. It's not a calming environment. Moreover, disruptive behavioral health patients can impact the care provided to other patients in the emergency department. Our behavioral health system needs to improve. Nevadans who experience a mental health crisis should be taken to an environment that is conducive for de-escalation, such as Crisis Stabilization Center or a behavioral health hospital. We're committed to working with you during the interims to tackle these difficult issues, and we appreciate all your hard work. And I like Fruit Loops.
Good morning, members of the committee. My name is Kinsey Sigler, and I'm with the group Act for Kids Nevada. I have been a proud Las Vegas resident for 27 years. I went to school here, I met my husband, and we had our 4 amazing children here. It is in this great state that we started our small business and plan to live out our American dream. For us, home truly does mean Nevada. Unfortunately, due to gaps in its children's healthcare infrastructure, we may not call it home for much longer. It is out of my love for this great state and the amazing families that call it home that I plead with you to agendize conversations for solutions to these gaps, including a freestanding children's hospital and comprehensive healthcare system. Families, including mine, need more access to specialty healthcare for our children. As a mom, I could spend the remainder of the meeting describing the gaps that my children have personally experienced, the challenges in accessing healthcare and specialists, how our amazing providers are under-resourced and overworked. But in the interest of time, I'll share one of our most recent experiences. Over the summer, my 12-year-old underwent brain surgery that resulted in life-threatening complications, additional surgeries, and many more unexpected weeks spent in the hospital. During this time, she did not want me to leave her side, and I did not want to leave hers, but I had to, in order to get referrals from multiple pediatricians and specialists for treatment for my other children. The process was grueling and overcomplicated, with the need for referrals from multiple offices. If all had gone according to plan, I would have driven a total of 33 miles between the 3 providers located all across the valley, but the odds were not in my favor. Referrals were lost in the pipeline between one provider to the next, resulting in back-and-forth drives, miscommunication, and ultimately a missed appointment with our subspecialist due to the delay in paperwork. And the next available appointment is over 4 months away, meaning my family's care will be greatly delayed. Imagine if all of these providers were under one roof in a freestanding children's hospital. How would my odds have changed that day? Nevada is known for playing the odds, but it is not thrilling when it comes to our kids. It should never be luck of the draw on whether or not you get an appointment or the help you need. Let's not gamble with our children's health. It's time for a freestanding hospital in Nevada to improve access to comprehensive specialty health care for our children. Thank you.
Members of the committee, my name is Chelsea Bishop. I'm here to speak on agenda item number 10. I'm a registered nurse, a Henderson native as well, and a mom of medically involved children. I'm here to ask you to agendize for future interim meetings the conversation about solutions to increase access to specialized pediatric care in Nevada, such as through the Comprehensive Children's Hospital. In 2015, I worked as a pediatric nurse on a local hospital floor before our oldest was diagnosed with stage 4 cancer. We traveled on and off for over 6 years of her treatment to Los Angeles, San Francisco, Salt Lake City, and Houston, before she unfortunately passed away in 2021. As we were in our other cities for healthcare, we noticed the incredibly large difference between comprehensive children's hospitals and the type of healthcare framework we have here in Nevada. Between the 4 of my children, we have seen well over a dozen different subspecialists throughout the Las Vegas Valley for their medical needs. We've had surgeries and multiple inpatient stays, so we're very familiar with the system here. Subspecialists are sprinkled all over the valley in different networks. This type of setup delays care for our children and is certainly not best practice. In addition, there are many gaps in subspecialists that are forcing children out of state for health care. I look forward to a future where this does not need to happen and our pediatric care is comprehensive in our state of Nevada. Accessing healthcare has been a large burden on so many families in our state. We've had some wonderful providers here in Nevada, ones we truly feel are caring and competent, but they are under-resourced and need better framework to work in. I'm part of a grassroots group called Act for Kids Nevada, and we are advocating for a freestanding children's hospital and a statewide health system for Nevada families. We are here to support any measures that will take strides towards this bright future for Nevada's kids. We'd like to work on solutions together. Thank you for considering how we can help improve access to specialty health care for our children in Nevada and for hearing my story today.
Good morning. My name is Leanne McAllister. I am the Executive Director of the Nevada chapter of the American Academy of Pediatrics. And the pediatricians of the Nevada AAP are committed to working with many of the parents that you've heard this morning and helping to meet their needs to access subspecialty care more easily. But we also have 2 other agenda priorities that the members have voted as the most important to them, and we ask that you prioritize them this interim session. The first is addressing the public health crisis of gun violence in our community, and the second is ensuring that children have access to high-quality, age-appropriate, and affordable health insurance. The Nevada AAP currently has 287 members, most of whom are board-certified pediatricians, both primary and specialty care. Members also include pediatric nurse practitioners, physician assistants, pediatric residents, and medical students, all of whom live and work in Nevada and have dedicated their professional lives to the health of all children. My role as the ED of the Nevada AAP is to connect physician leaders at our chapter to you, our legislators, to ensure that you are aware of the most recent evidence-based pediatric care thinking available as you make critical governing decisions for our state. I am at your service.
Good morning, Chair, Assembly. My name is Jason Greninger. I'm with the Coalition for Patient Rights, a certified surgical technologist and a resident since 1989. Coalition for Patient Rights provides a voice for the people, aiming to improve the health care of the nation by highlighting systems failures, lobbying, and advocating for regulatory change, treatment education, environmentally friendly policies, and safeguarding new technologies. And we would like to address at some point with you and potentially with some BDRs on the need for Nevada's MMP program changes, which are well past due, as patients have not had any true bills that have supported their needs since 2017. Industry has left patients with no voice or rights in protecting them, and patients are still needing that care. CPR will be championing and seeking their support and voice in supporting 1, a DUID reform bill for patient exemptions, considerations, and 2, MMP program protections and updates, such as plan limit increases, removal of HALO for all patients, full tax exemptions, removal of registration fees, removal MMP application barriers, and easier, faster application processes. And these are just a few of the main needs. We at CPR seek truth, we speak truth, and we're determined to find that truth as we find our patient rights are best protected by transparency and open dialogue. Thank you.
Good morning, Chair Dunyate and members of the Health and Human Services Committee. My name is Ken Kunke, and I'm a practicing pharmacist here in the state of Nevada, and I represent the Nevada Pharmacy Alliance. We want to thank the Nevada Psychiatric Association for bringing their concerns to you. I feel that the concerns have been alleviated by the 2 letters that were submitted by Roseman University and the Nevada Pharmacy Alliance. Pharmacists go through extensive training, and to get a DEA license, they will have to do 8 hours of training based on medications for opioid use disorders. Also, I want to point out that pharmacists prescribing medications is not new for Nevada. We're already allowed to do that for prevention of HIV. So training, the referral process, all healthcare providers do that. If there's something that we can't handle or there's someone that could do a better job, obviously, all healthcare providers provide referrals. Finally, I just want to point out that if they feel that the statutes or regulations are hindering their practice, we encourage them to look at getting those regulations or statutes changed and not hindering this service, this access to care for patients in Nevada for opioid use disorders. Thank you so much.
Thank you so much. Anyone else here in Las Vegas? Anyone in Carson City? And anyone virtually?
Thank you, Chair. The public line is open and working. However, there are no callers at this time.
Thank you so much. That concludes public comment. We do have one at the end of the meeting, so if folks didn't have the opportunity to, we can always come back. We're going to move on to the next agenda item, which is the review of the interim work program. We have, for this presentation item, Mr. Ashton and Mr. Florence, so please proceed when you're ready.
Thank you, Chair Dunyate. For the record, Patrick Ashton, Committee Policy Analyst with the Research Division of the Legislative Council Bureau. So, as nonpartisan legislative staff, I cannot advocate or oppose any of the proposals that come before you in this committee. I'm here to assist the Chair and members with any questions concerning policies that may arise. My colleague Davis Florence and I are available to assist the committee and its members on any issues related to health and human services. In addition, the Research Division is available to provide information and assistance on a confidential basis to each member of the legislature on any topic. Please feel free to reach out to me or my colleagues at any time. So we will now review the interim work program, and I will start with responsibilities and duties of the Joint Interim Standing Committee on Health and Human Services. After that, I will hand it over to Davis Florence to provide you information about required interim studies, audits, publications, and reports, and some other relevant information. Before I begin, I want to mention that an electronic copy of the interim work program has been uploaded on the committee's website. You should also have a hard copy in your meeting binder. On page 1 of the document, you find a list of the members and alternates appointed to the HHS committee, followed by a section on the committee's authority and responsibilities. I will focus on the latter part. So the committee considers a wide range of HHS topics, including child welfare, healthcare and health insurance, behavioral health, public health, safety and welfare, and food, drugs, and cosmetics, among many other issues. As you may know, this Joint Interim Standing Committee is the successor of the Legislative Committee on Healthcare. Its primary responsibilities and duties were transferred to this new HHS committee during the 2021 session, including reviewing and evaluating the effectiveness of programs to prevent illnesses, analyzing the overall system of medical care in Nevada, and coordinating service provision to avoid duplication of efforts. The committee may also review issues related to health insurance, hospitals, medical malpractice, and health-related regulations, which we will have later today as an agenda item. Additionally, the jurisdiction and membership of the Standing Senate and Assembly Committees on Health and Human Services from the 2023 session are reflected in the Joint Interim Standing Committee on Health and Human Services. So the committee may request a total of 15 bill draft requests or BDRs. 10 of those are within the scope of the committee, and 5 of them are limited to matters or issues that address child welfare matters. And the committee must conclude its work on or before September 1st of this year. So at this point, Chair Doniate, I will hand it over to my colleague, Mr. Florence, who will continue the presentation from Carson City. Thank you.
Thank you, Chair. Davis Florence, LCB Research. For the record, to continue on with our presentation of the work program, you will find that the 2 committee-mandated interim studies are on page 2. First, we have Senate Concurrent Resolution 5, which requires the committee to review existing cardiovascular screening programs in Nevada and how state agencies may collaborate with federal agencies, programs, and private organizations to evaluate and possibly expand those programs. The second study comes from Assembly Bill 155, which requires the committee to study the cost effectiveness of biomarker testing. This study will be done in coordination with the Department of Health and Human Services, and the bill included an allocation of $325,000 to the Division of Healthcare Financing and Policy to contract with a qualified provider to conduct that study of cost effectiveness. In addition to the two mandated issues above, the committee will focus its time on 4 primary topic areas, which Chair Doniate mentioned earlier. These include access to healthcare, behavioral health, healthcare infrastructure and workforce, and public health. Moving on to page 3 of the work program, you will find relevant audits, publications, and reports relating to the work of the committee. In addition to the work program, this information can be found on the legislature's website, or you can reach out to staff and we can assist you with finding these resources. On page 4, you will find a list of the scheduled meetings for the committee. I would like to note a tentative joint meeting with the Joint Interim Standing Committee on Growth and Infrastructure has been scheduled for July 17th, pending approval from the Legislative Commission. And lastly, you will find all of the staff assigned to the committee at the end of the work program. And with that, this concludes our presentation. We stand open to any questions. Thank you, Chair.
Thank you so much. Any questions from the committee members at this time? Seeing none, we'll go ahead and proceed to the next agenda item, which is agenda item number 4, consideration of regulations proposed or adopted by certain licensing boards pursuant to NRS 439B. So really quickly, for this presentation item, we have Mr. Robbins, who will go over a few of the regulations. As you may notice, some of them have already been approved. Some of them are up for approval. It is the role and responsibility of this committee to at least have them come back and for us to provide feedback if there's still an opportunity to do so. there are a lot of regulations, as you may have noticed, on our agenda because we haven't met in quite a bit. And so we'll go through them, and then we'll have committee members, if you have any pressing questions on or comments on any of the specific regulations, then that will be the time period when you could do so. So let's go with Mr. Robbins.
Eric Robbins, LCB Legal, for the record. So Senator Doniate just asked me to kind of provide an introduction to this topic for the purposes of the committee going forward. So to that end, NRS 439B.225 requires the committee to review each regulation that certain licensing boards that license health professionals or healthcare facilities propose or adopt that relate to the standards for the issuance or renewal of licenses, permits, or certificates of registration issued to a person or facility regulated by the board, giving consideration to any oral or written comment made or submitted to it by members of the public or by persons or facilities affected by the regulation, the effect of the regulation on the cost of healthcare in this state, the effect of the regulation on the number of licensed, permitted, or registered persons and facilities available to provide services in this state, and any other related factor the committee deems appropriate. And as Senator Doniate mentioned, some of the regulations have been adopted and approved by the Legislative Commission and are effective. This is an entirely separate process from the approval process by the Legislative Commission. The committee doesn't take any formal action on these regulations, but the committee can provide feedback and suggest ways to improve regulations that are still in the proposed stage, or maybe recommend changes to NAC sections that have already been adopted for the adopted regulations, or even include something related to any of these regulations in its bill draft requests at the end of the interim. So normally the way this goes is that there are representatives from each agency here to answer questions for the regulations. Because the regulations are so numerous, I'm not going to call them out individually, but if any member of the committee has questions about a particular regulation, they can let the chair know, and then the chair can hand it over to that member of the committee, and the representative of the relevant agency can come up and hopefully answer the questions. So that's all I have.
Thank you so much, Mr. Robbins. So again, because we have quite an extensive list of regulations that have either been approved or are up for consideration, what I'll do is, if there's any members right now that would like to highlight one that you have a question on, we can go and we can circle all the ones that we have. That way we don't waste time on the ones that we don't have any questions on. So for instance, I'll go first. The one that I will pull aside is LCB file R69-23 of the Board of Medical Examiners. So that will be one that we will discuss. So the Board of Medical Examiners will answer any questions that we may have. Are there any other ones that the committee members would like to pull aside? Maybe anyone in Carson City? And even if it's not a question, but it's more of a comment, that's fine as well. Vice Chair Ornlicker.
Yeah, so I'll want to comment on R05923, number 10, I think.
Any other ones? Anyone in Carson City? Any other ones that we would like to pull out?
We're good down here, or up here, Mr. Chair.
Thank you so much. All right, let's proceed to 4G, LCB file R069-23 from the Board of Medical Examiners. So my understanding is this is a proposal that is being considered by the Board of Medical Examiners. So if there's any representatives, you can obviously come forward. But when I was, considering that this is up for consideration, I think my concerns are more comments, and I actually had LCB research as part of what my comments will be. It's interesting that my understanding of this regulation, and of course it could be corrected based on what is being proposed, was that it is coming to fruition based on the activity of the legislative session. And it is setting up the proposal for anesthesiology assistants to be able to operate in this state. And part of the question that I had was, oftentimes I think when we are creating new regulations for new licenses or new practitioners to operate in this state, sometimes we take portions of law or administrative code that can be replicated from one thing to another. That doesn't mean it's always right, and that's kind of what my line of questioning is today. And so the first thing that probably I wanted to push back and just maybe inquire on is on Section 3 of the regulation. In Section 3, subsection A, it requires that a person who wants to be licensed as an anesthesiologist assistant must be able to communicate adequately orally and in writing in the English language. And so I guess my first question is, does this appear in administrative code for other licenses that are under the Board of Medical Examiners? And if so, what's the rationale for that?
Chair Donate, this is Sarah Bradley, Deputy Executive Director on behalf of the board. I believe that comes from a regulation for practitioners of respiratory care. And I think your point that you started with is correct. I know at least initially when we were looking through our existing regulations to see what we might need for this new license type. And so I believe that's where that came from. And I believe the examination for certification is only provided in English as well. So I think they would need to be able to pass that exam, obviously, and be certified to be licensed pursuant to AB 270.
Thank you so much. And that's kind of what I expected the answer to be. I think as part of the recommendations that you guys should take back to the board and do some more work on, I was thinking about this the other day. English proficiency does not dictate the competency of being able to do your job. If we had the best surgeon in the world coming to Nevada to do a neurosurgery, it doesn't matter if they're able to speak English. If they're able to perform the action that they can do so, I think that is something that we should obviously entertain. If the exam is only being done in English, but we have practitioners that want to move in this state that have range of years of experience, I think that we should expand those opportunities. And so that is the only thing that I wanted to push back on. I know that in other provisions of the regulation, and again, I think it's more so standard practice, I believe there's a disclosure that requires providers to disclose the prescriptions that they're prescribed to and whether or not it would impact the matter of their work. We have heard from physicians and from other professionals that the application process right now through the Board of Medical Examiners can stigmatize those who suffer from mental health conditions, and they may not have the welcoming of disclosing those medical conditions simply if they ever received any sort of counseling, et cetera. And so I think we should be mindful of these conversations as we're approving more regulations. And I, for one, believe that we should simplify, not add more. And I think that is part of the review process that we'll probably have in coordination. And hopefully we can bring you back in the March meeting. But that's the only thing that I wanted to mention. Again, I think you need to go back and make sure that all the regulations that you have under the Board of Medical Examiners are revised and we take out the English proficiency, because I just don't think it dictates anything. But that's just my personal opinion. Any other comments on this proposal? Nope. All right, we'll move on to the next one. The next one that we pulled out was agenda item R, which is LCB file R05923 of the State Board of Pharmacy. So Vice Chair Ornlicker, please proceed.
Thank you, Chair. And I would just like to commend the Board of Pharmacy for its work on this proposed regulation. As we've heard from some of the public comment, this addresses a serious problem we have in our state with opioid use and a serious problem with overdoses. which at the same time exists where we have good treatments that are just not reaching people who can benefit. Only 20 to 25% of people who have opioid use problems get the treatment that will help them. This bill, AB 156, that we passed last year, is designed to implement best practices for substance abuse disorder, and I commend Executive Director Dave Wiest and the Board of Pharmacy for acting in a timely and careful manner to draft a regulation that will effectively implement the bill and assure patient safety. And they've made necessary adjustments as comments have come in, and they've also properly rejected some requests that are meritless, that ask them to duplicate existing regulations, or that even ask them to nullify the bill. So thank you to the Board of Pharmacy for acting correctly and efficiently and in a very timely manner. This bill and the regulation allows us to take full advantage of our existing health professionals and their skills. We have a serious shortage of health professionals in this state. And one of the problems is we don't even take full advantage of the resources and skills that we already have. And this bill does that with pharmacists to address a critical problem. So again, I want to commend the Board of Pharmacy and Executive Director Dave Wiest for their work. Thank you, Chair.
Thank you so much. Any other comments on this item? Any other regulations that we want to pull before we move on to the next agenda item? All right, let's go ahead and close this agenda item. We will now move on to the presentation on Nevada's health rankings and priority issues to consider for the committee. For this one, we do have Ms. Kamlasi, who is the Director of Public Affairs and Policy from the School of Public Health at UNR, so please proceed when you are ready.
Thank you, Chair Doniate and members of the committee. My name is Megan Kamlasi. I am the Director of Public Affairs and Policy at the UNR School of Public Health, and I just want to thank you for the invitation to present to you this morning on the state's priorities for improving healthcare and reducing health disparities. I do have a presentation that I have on the computer. Oh, I don't know if it's up. Okay, cool. Over the past couple of years, the state's Division of Public and Behavioral Health has funded the School of Public Health to lead a couple of projects that look at health needs throughout the state, to identify some strengths and challenges, and then outline a number of priorities to focus on over the next couple of years. And so we'll talk about both of those projects. The first is the 2022 State Health Needs Assessment. It's a report that describes the current health needs of Nevadans. It included a significant amount of data compilation from state and federal sources, as well as input and feedback from residents. More than 2,000 Nevadans participated either in a community survey or focus groups to provide information on their health and factors that influence it, whether physical activity, nutrition, access to healthy foods, barriers to accessing healthcare generally. And so all of that data is compiled in the report, and the report paints a picture of what health needs and challenges and barriers are throughout the state. We don't have enough time to review all of the data in the report today, but I included a link in the slides, and I noticed they're not on Nellis, but we'll make sure that you have the link after the presentation. But what I really want to talk about in alignment with Chair Doniate, your goal to talk about solutions, is how we're translating all of this data into action. So the second project that the School of Public Health has worked on over the last more than a year, really, is the State Health Improvement Plan. This is a first of this type of plan that we've ever done in Nevada. So as the State Health Improvement Plan, we also call it the SHIP, so I'll refer to that as that for short. But the SHIP builds on the 2022 Health Needs Assessment. It considered additional information from other sources, and it was developed in collaboration with close to 100 stakeholders, and they were representatives of a variety of sectors and organizations. And the plan essentially provides a roadmap for DPBH and community organizations to work together to improve the health of Nevadans. It provides guidance to state and local agencies, to community organizations and other stakeholders to take steps to improve health. It can serve as a tool to create and refine priorities, to prioritize resource allocation, and also to develop and implement projects and programs and policies. And it also provides a foundation from which we can take collective action. Essentially, anyone looking to make a difference in the health of Nevadans can look at the State Health Improvement Plan, review the priorities, goals, and objectives it outlines, and then come away with an idea of the best direction to go. But the idea in making this as a state plan rather than just a plan for DPBH or DHHS is that we can accomplish more and make more progress together if we're all moving in the same or a similar direction. So it really is truly a statewide plan. This slide outlines the process used to create the SHIP. There was tons of community involvement. We had a steering committee that developed a list of possible priorities. We used a community survey to narrow those priorities. We had subcommittees for each priority that was chosen that delved more deeply into the priority and identified sub-areas of focus within those priorities. And then we consulted with subject matter experts to really inform the goals and objectives that were ultimately included in the plan. So these are the SHIP's 4 priorities, and the intention of the plan is to help guide collective action to move the needle on each. These are largely similar, it sounds like, to what this committee is going to be working on over the interim. A lot of them also are reflective of some of the public comment that you heard this morning. Access to care, mental health, and substance use. And these are all super broad issues, but the SHIP narrows the focus of each by identifying 3 or 4 key areas of focus within each priority and then creating a goal and a number of objectives for each of those issues. I'm going to walk through the priorities and the focus areas within each this morning, and then if you're interested in the specific goals and objectives that are included in the SHIP, they're included at the end of this slide deck. They're also included in the actual plan. And the actual plan is not posted to DPBH's website yet. It will be soon, and we'll provide you the link to it as soon as it is. But when you take a look at it, you'll see that it provides some context and additional information about each of these issues, including recent efforts to address the issues, what's planned for the near future, and then you'll see the goals and objectives. Let's see. So the first priority area is social determinants of health, and social determinants of health are, as you know, are the conditions in which we live, work, play, age, worship, all of the things. And we know that those conditions are more impactful on health and more determinative of our health outcomes than things like genetic factors or access to care. So they're super important to look at. The SHIP subcommittee could have chosen a whole host of different social determinants of health, but ended up landing on the 4 on the screen. Food security relates to helping ensure people have reliable access to affordable and sufficient and nutritious food. Health literacy is essentially the degree to which people are able to find, understand, and use information as they make health-related decisions. It's also how organizations, healthcare organizations, provide information to people, how difficult or simple they make their systems. Air quality and climate change largely came about due to a number of comments and concerns with smoke from wildfires, as well as other air quality issues. And then housing was also a large topic of discussion and something that we saw in the state health assessment. And the SHIP subcommittee zeroed in on supportive housing as a specific type of housing that's needed. It combines affordable housing with intensive coordinated services to help people maintain their housing. So perhaps, if there's an individual with mental illness, they may have supportive services to review the terms of the lease or ensure that they're paying their rent on time. If there's an individual with chronic illness or chronic conditions, they may get help managing their diet or ensuring they make it to medical appointments so that they don't end up in a hospital or nursing facility. With regard to access to care, you've heard this morning multiple times already that this is a huge issue in Nevada. It's an issue both in rural and urban parts of the state. And a lot of the challenges that people face in this area really trace back to that severe shortage of healthcare providers that we experience in Nevada. Probably we've all experienced issues either getting a timely appointment or finding the right specialist or finding a person in Nevada who can address our needs. So healthcare workforce is a huge issue and 2 of the subcategories in this priority, and the other one is access to oral health care, which is a significant issue, especially among certain groups and in rural Nevada. Oral health care influences overall health in a variety of ways. Oral diseases cause pain and disability, but they're also linked to things like diabetes, stroke, and heart disease. And we see in Nevada that tooth decay is especially problematic among young children. And we know that that sort of tooth decay influences young people's health and development. So really critical things to address in Nevada, especially in underserved areas. I would like to say that we have seen a lot of momentum in these areas, especially related to workforce. The legislature, you all passed a number of bills last session that aimed at improving the health and behavioral health care workforces, which is huge. So we're taking some really great strides in the right direction, but there's a lot still to do. Mental health and substance use were two of the top issues identified in the state health needs assessment. And I think we all see and feel this between the opioid epidemic, drug overdose death rates. Suicide is still a huge concern. I mean, last year, the U.S. Surgeon General produced an advisory related to what he called the epidemic of isolation and loneliness and its impact on mental health, and that's not even to mention all of the behavioral health issues or impacts of the COVID-19 pandemic. So this is a huge need. We also know that there's a ton happening in Nevada related to mental health and substance use, and it was challenging through the process to narrow the focus of this priority, but our SHIP subcommittee decided to focus behavioral health issues to those that have a statewide impact or the potential to be expanded statewide, that involve major systems change, that require state resources, and that are being addressed through collaboration of various partners. So the areas that meet those criteria first are children's behavioral health, and this is really in light of the 2022 Department of Justice report, an investigation that found that Nevada over-institutionalizes children with behavioral health needs and the need to instead provide more community-based services. Second is the crisis response system. So this relates to 988, which you are all familiar with from funding it over the last couple of sessions. It's the suicide and behavioral health crisis lifeline that people can call or chat to get assistance, but it's an entire system. It just doesn't stop with the 988 call line. Nationwide and in Nevada, we're working on developing a system that aims to ensure that individuals and families in crisis have someone to talk to, someone to respond, and somewhere to go. So in addition to 988, that includes mobile crisis response and crisis stabilization centers. The third item is improving and increasing substance use prevention, harm reduction, treatment, and recovery services, that whole spectrum. And then finally, we had to include this as an objective because throughout the SHIP process, what we heard over and over and over from behavioral health experts is having a robust behavioral health system really relies on sustained and comprehensive funding. And it needs to be more funding than we have had in the past, and we cannot and will not improve the system without significant and ongoing investment. And it can't be taking from funding that's currently available and going to services and putting it somewhere else. We need to expand the pie of funding, and whether that's looking at new sources or leveraging existing sources in new ways, just really need to increase funding. I also want to note that the SHIP builds on a ton of work that's happening across the state in these areas, and it's happening at all levels, from the smallest community-based organizations all the way up to state departments. And the SHIP's goal was to highlight and elevate the work that's happening and to build on it rather than duplicate it. So a ton going on here, could have focused on a million issues, and these are those that were included in the plan. The final priority is public health infrastructure. You all know from this past session and other experience that public health serves a critical role in keeping people healthy, but that work and those systems are often invisible. You don't see the public health work that's happening necessarily. You also know that public health is different than individual health, the health care you seek in the doctor's office or at the hospital, because it focuses on keeping entire communities healthy and safe, doing things like preventing and controlling infectious disease and making sure water is clean and the food we get at restaurants doesn't make us sick and that sort of thing. And we know that the COVID-19 pandemic brought more focus on public health than ever before. And it exposed a number of issues in the public health system that we didn't realize were there, but that need to be addressed so that the public health system can better respond to public health crises in the future. So the SHIP focuses on, that's where these specific subcategories came from. We've made progress in a lot of them. A huge thanks to you all for passing Senate Bill 118 last session. It provided the first flexible funding ever to local public health authorities to address the issues that they need to in their communities. And that, I mean, it's such a huge step forward and a really good start, but sustainable funding is what we're going to need if we're to address all of those systemic issues that are the result of decades of chronic underfunding in the public health system. So then the other issues, public health workforce, we see high vacancy rates in some public health agencies. We also know that we want a highly qualified public health workforce if we want them to keep our communities healthy. This is also a field that is heavily reliant on data, collecting and compiling data and then easily communicating it out to partners to stop the spread of disease and that sort of thing. And we really, there's a significant need for modernization, and steps are currently being taken, but we need to take additional steps. And then the final piece is really identifying opportunities to engage with communities and ensure public health systems meet their needs. So an example of this is the recent creation of the Central Nevada Health District, which is the first rural regional health district in the state. It was created by 4 counties, or in 4 counties, that came together and said, we think we can deliver public health services better to our people. We understand our needs better. We can do this, and we want to do it. So really ensuring that all communities have that opportunity. So just a little bit in terms of next steps, we're working on developing an action plan for each objective that's included in the SHIP, and we're compiling them into a comprehensive plan. We're working to implement them. We're going to track implementation and report progress through DPBH's forthcoming performance management system, so we're building an accountability. And then we'll be reviewing and revising the SHIP action plans annually through 2028. But what is really important to you is what the SHIP means to you, or why you should care, or how you can use it. And so essentially the SHIP can be a tool to you as policymakers. You can consider the priorities outlined in the SHIP as you think about issues to consider either during the interim or the legislative session. It seems like there's already a lot of alignment with what Chair Doñate is planning to consider and the SHIP. You can review and identify specific goals and objectives that have policy options or policy solutions, and then consider policy options to meet those needs for potential BDRs. And then you can also encourage community organizations, agencies, stakeholders in your districts to become familiar with the SHIP and align their work to it as well. Because if we're all working in the same or a similar direction, we're going to accomplish more in all of these priority areas than we would individually. So that is all I have. It looks like, again, my presentation is not on Nellis, but what you will see when you see it is that it includes each goal and objective at the end of the slide deck. And I would be happy to answer any questions, and there are also representatives of DPBH here if they can be helpful in answering questions as well. Thank you.
Thank you, Ms. Komlasi. So just the way that we'll handle these presentations, if you notice that many of them start with the context of problems, and then there's solutions, and now we're in the question and answer period, also the more of a conversation, right? I think we can ask our presenters as we're going through each of these presentations and throughout this interim about what their perspectives are and how we can tackle some of these challenges. The reason why I wanted this presentation to go first is because this is the ground that we currently sit on. We know that there are plenty of issues that can go into healthcare, but we can't solve all of them all in 1 year or in 2 years. And so these are the areas that we should be aligned towards. Coincidentally, I did not plan for the priorities when we were working on the work plan to be the same as this presentation, but I think it's timeful because a lot of this is aligned in addressing the pressing needs. And so we can ask any individual questions that we may have on what was presented. We can offer feedback. We can ask for their personal recommendations. And so I can go ahead and let the committee members ask any questions at this time if they have any. So, Assemblywoman Brown.
Thank you, Chair. Thank you for the presentation. My question is really relative to the timeliness of the projected action plan. Do you have an estimated delivery date? How quickly are you working on the action plan?
Thank you for the question, Megan Kamlasi, for the record. We are working on it currently. I would say it's probably half done, and we'll probably have the actual action plan done in the next month or two. And essentially what the action plan is that it's going to include an action plan for each objective that is created either by someone within DPPH or a partner organization. It is not going to reflect all of the work that's being done to implement or align with the State Health Improvement Plan, but it'll essentially provide examples of the type of work that is being done to implement the plan. But also happy to share that with you as soon as it is completed.
Thank you so much, Senator Titus.
Thank you, Mr. Chair, and thank you for, Director, for putting a very difficult subject in kind of a pretty straightforward narrative, kind of making sure we understand the difference between what's best for the public health individual and then making sure that we still respect individual rights and liberties to healthcare is always a challenge, and you did a really great oversight on that. One of the question I have, and we'll deep dive into this later on and throughout this whole interim, we heard earlier in public testimony regarding pediatric care in Nevada and how it's really disjointed and no one place to go. A standalone pediatric hospital, although it is a great idea, it absolutely costs an incredible amount of monies and takes a lot of work and time. Having said all of that, you mentioned children's mental behavioral health, and I'm just wondering where we are in the process. I know the state has had issues, and we're undergoing some litigation because of the placement of institutionalization of some of our children. But my question really is, how many kids do the state take care of on out of state, and we are located out of state? Because it's all relevant to looking at something we can do within our state. And so could you give me a quick update on that, please?
Julia Peak, for the record, Division of Public and Behavioral Health. I will have to get back to you unless Megan's pulling it up right now on our dashboards. I do want to get with our division, our sister divisions on this. What I will note, though, is this, the SHIP and the work being done here is not the only effort occurring. In the interim, our Nevada Department of Education actually developed a working group, which is all our sister agencies at DHHS, community partners at our universities, and the Nevada Department of Education, and we're going through trying to figure out what we can do in the area of children's health with their families as a wraparound service. Behavioral health, of course, rose to the top of that. Physical health later, but we have more in physical health than we do in behavioral health. So we're putting forward some great ideas and recommendations of how we could do differently. Also looking at grant funds that could potentially help us, and that's across all of the agencies. So good work being done in that I just want to highlight, but we can get you data unless Megan wants to speak to that right now.
Megan Kamlasi, for the record. I would just note that DHHS has a data dashboard that identifies children and youth out of state placements. So we can provide this link to you, but they have data on how many are out of state at the end of the month, admissions, discharges, total placements, those placements that last more than 15 days. So there's a ton of information, and they update it. It's at least monthly.
Great. I'm sure all of us would like, perhaps you could share that link with all of us. I think it's good information to have as we move forward and get some priorities what this possible committee can do and recommend on a statewide basis. So thank you for that.
Thank you so much, Senator Titus. Any other questions in Carson City? Anyone down here? Ms. Kamlasi, I do have a quick question, and it's probably more of just your personal feedback working in public health. I want to ask about the public health infrastructure. There's workforce, data, IT modernization, and of course, governance. I know in the last legislative session, we worked on SB 118 that would establish the continual funds, right, that could help with public health entities coordinating together in response to new outbreaks, et cetera. But that proposal was structured under a per capita rate, which we needed, right, in order to achieve the gaps that we have in our funding for public health. You alluded to the fact that we also need to figure out a sustainable funding mechanism for it. But I guess my next question, my real question is, we want to make sure that we empower the new health district that has been stood up in the rural areas, but there are still some counties that haven't joined that district. And so what do you see in terms of the future of public health so that counties that haven't participated in that health district also are uplifted, and we can drive and empower local jurisdictions to also have a stake in terms of delivering and improving public health? Do you have any recommendations? Does the future of the per capita rate, should it change? Should it modulate? Do we provide a base, and then do we provide them more funds based on performance? Like, I guess it's part of, like, what do you foresee as a progression for this legislation?
Thank you, Chair Doniate. Megan Kamlasi for the record. Really great question. And currently our partners at the Nevada Association of Counties are conducting assessments in all counties in Nevada, looking at how foundational public health services are provided and providing that information to local officials to have the information they need to determine whether they would like to establish a local health district similar to the Central Nevada Health District, or on their own, whether regional or single county or single entity. So NACO is working on that assessment and doing it in conjunction with I don't know what the acronym stands for, but NEEP, the UNR's NEEP program. They're economic people who look at all of the data and numbers. So they're pulling that information together as we speak and meeting with, I think they've met with 6 additional counties to provide that information, and they will work on, they're currently planning on meeting with the rest of the counties to pull that information together. So that piece is moving forward. I'm going to defer to Julia Peak, if that works for you, on the funding piece and where we go from there.
Chair Doniate, if it's okay, Julia Peak for the record, Division of Public and Behavioral Health. I do want to just acknowledge the work of NACO. A silver lining in COVID is the partnership we have with NACO now in public health. They have a public health liaison that works with us. In addition to what she's doing with the Foundations of Public Health, she's also working on the SB 118 funds, and some of the feedback we've heard from the smaller rural counties is that it should be a funding formula with a level of infrastructure base, then a per capita on top. Not atypical. We've done funding formulas in the past, so we're looking forward to talking with NACO and getting that feedback and figuring out what that might look like if it's different. As you know, SB 118 is not ongoing funding. It was a one-time appropriation. It starts July 1st and then goes that year, and then they could spend the following year as well. So we're really looking at Foundations of Public Health in that regard. And then what the individual county sees as the need. And that's really how the bill was designed, for them to dictate what that looks like, and then we provide the support to make that happen. I will note that there are several counties working with NACO to remove the assessments in 439. And so that's really a first step, and you saw that with the Central Nevada Health District. So they're expressing that they would like to no longer pay DPBH to do that assessment on their behalf, and it really includes infectious disease response nursing and environmental health services. And so that will come forward to the governor, and then if he supports it, recommendation onto IFC. And so that would be the first process of standing up local public health services. And so there are a few counties not ready to present which counties yet, but NACO's doing a great job helping them walk down that path.
Thank you so much. Yeah, and if as you're going through this process, Ms. Peak and Ms. Kamlasi, if there are any recommendations that you have in terms of implementation or reconsiderations, I think that's something that we need to make sure that we prioritize. So thank you for that. Any other comments or questions? Seeing none, we'll go ahead and close this agenda item and move on to the next one. Our next presentation is agenda item 6, the overview of objectives and priorities at the Department of Health and Human Services. We have with us Director Whitley and Ms. Shannon Litz, the Deputy Director of Programs for DHHS. So please begin when you are ready.
Thank you. Thank you, Chair Donate, and members of the committee. For the record, my name is Richard Whitley. I serve as the Director for the Department of Health and Human Services. And with me on my left is Debbie Reynolds. She's the Deputy Director over Fiscal Services. And on my right, Shannon Litz, who is the Deputy Director over Programs. I was asked today to present on some specific focus areas, and I think before that, though, it would be good for me just to lay a little bit of the foundation of our agency. Sometimes to a fault, we try to be all things that are needed, and you'll hear when I talk about the post-COVID environment, just, with workforce and those things, some of the challenges. But I think it's important that I just lay out a little bit of our infrastructure. And so on slides 3 and 4, you can see our organizational chart. We're organized in divisions. Our role, really, though, regardless of divisions, sort of fall into functional areas. We deliver direct services, we fund direct services, and we regulate direct services. With Medicaid being the largest payer of healthcare, and you'll hear from them after my presentation, we do this with a workforce of about 7,300 employees, and our budget is a little over $8 billion annually, with funding sources being state general fund and federal funds, fees, settlement funds. The largest use of funds, of course, are with Medicaid, and as the payer of healthcare. Moving on to slide 5, our agency priority areas. So like you've heard previously and from you, Chair Donate, access to care is one of our priorities, but I think it's important to acknowledge where we came from. In 2012, prior to the Affordable Care Act and the expansion of Medicaid, Nevada's uninsured rate was 72%. I think it's important because most of the policy making as it relates to healthcare has been incremental and, didn't happen overnight. And so as we manage expectations going forward, I think it's important to look at that. On access, you have the people and then you have the system of care. For the people, we're currently at about 90% people insured in our state. So who is that 10%? Are they choosing not to be insured? Are there barriers? Are there disparities in terms of populations? That's an area we're looking at to see, are there people out there that we could outreach to more to make it easier to get enrolled and to have healthcare coverage? The other component, though, of access is the actual healthcare system. And I think that the governor and the legislature passed both in budget and in legislation unprecedented rate increases and services for the healthcare network. And I think as we see that sort of shake out in terms of the more robustness of the healthcare, I think that will definitely improve access. I think as mentioned earlier, when it comes to access, we have some clear deficits. You heard about pediatrics, but really in that space of primary care, trying to prevent perhaps inappropriate use of hospitalization, that we do have deficits. I think there was a question related to the Department of Justice substantiated complaint for children's behavioral health. And it really, the specifics of the complaint, public document that anyone can look at, really is overutilizing or relying on institutional levels of care when home and community-based services likely could have prevented that hospitalization. We've been working for the last year with the Department of Justice on an agreement, and it's been although what caused us to have to do this, not good, I think the process of actually looking at, you have data in one place and you have advocates in one place and, bringing everything together in a way to actually put together a package of services that actually could prevent hospitalization or institutionalization of children for behavioral health needs has actually been probably a highlight in my career of just being able to detail that. Many states have had these findings. What's different for Nevada is the governor's bill, Senate Bill 435 that the legislature passed, allowed us to take 15% of the voluntary provider tax for hospitals and utilize 15%, up to 15% of that to invest in children's behavioral health, to actually address this deficit that was identified by the Department of Justice. So we're finishing up that project with the Department of Justice, finalizing the agreement, and we'll be going to the Interim Finance Committee with a package that will detail out the services for children, for home and community-based services. And it isn't just adding new services, it's also looking where we perhaps needed to increase rates because we have service providers, but not providing the services because the rates are too low. So happy to provide an update to this body, as well as we will, those of you that sit on interim finance, we will be presenting before you the logic on the new services and the logic on the rate increases going forward. That's really the most specific I can get because we haven't finalized or signed off on the agreement yet with the Department of Justice, but we've been having weekly meetings with them, the Medicaid team and clinicians from the Division of Child and Family Services. So just wanted to revisit that question that came up in the last presentation. That all goes to access, and I do think that none of these issues are simple, and none of the solutions are simple, but I think the primary care piece is clearly an area for other populations, seniors, adults, that we're focused on how we can move the dial as it relates to healthcare and preventing really the inappropriate use of the emergency room or the hospitals, so getting that care at the community level. That a big part of that access then is workforce. Again, a complex issue, and it isn't just doctors and nurses, it's all the allied healthcare clinicians that allow doctors and nurses and others to play to their, or provide services to their highest scopes of practice. And so, as I think you'll hear at the end of my presentation on an update on ARPA funding, I think that we have demonstrated some really great benefits from investing at different places along the pipeline for workforce. And I think that focus, whether it's the licensing board, because it's not all about making new providers, it's also inviting providers out of state to more easily enter our state with their licensing boards, and not always easy. And if you have a husband and wife, which we have had, and they're in different disciplines and their boards work at different paces, presents a big challenge. And so I think the complexity of the healthcare workforce, even who's attracted to that clinical workforce. For example, social workers, there was another committee this week on people with disabilities and seniors and veterans, and social work came up as a discussion point of vacancy where there are vacancies. We know that people are attracted to that discipline who sometimes have had life experience that have allowed them to utilize social services. And so the investment in scholarships is really important in the pipeline, not so much loan repayment at the back end, but in the front end. And so where we invest along the way with workforce, I think is critical, and knowing what that workforce looks like and what would actually move the lever for those populations. So again, just I heard the guidance in the beginning about coming with solutions. I think there is definitely opportunity for a deeper dive on workforce, not just declaring the problem and not just focusing on a handful of providers, but we're looking at some positive things that we've learned out of the pandemic that skilled nursing facilities and hospitals have been able to do just by leveraging out of necessity the scopes of practice. And with nursing, national shortage, definitely a state shortage, a shortage before the pandemic. If looking at why that is with our universities and the production and the education pipeline for nurses, as well as how nurses enter our state and how do we sustain them. Those are all very complex and really do need the detail. I mean, I think as an agency, what we're looking at is not thinking single solutions are going to solve the problem, but really how are we incrementally moving towards that, and is it based on data? Workforce being really a key to access. Finally, healthcare quality and outcomes. Hopefully, you've all noticed that what a transformation has occurred in our Nevada Medicaid program with all new leadership, really. And that's in no way to take away from the past leadership. Again, incremental. It was the past leadership that allowed for the current leadership to really move swiftly in making changes. But one of the things that I think that we're seeing that we'll continue to utilize is when it comes to quality is incentive payments. The health, it really does and motivate health plans to serve. You heard from Ms. Clamasi about determinants of health. They have flexibility in their provider payment to actually provide services that we can't as a program for fee-for-service directly reimburse, but they have a wider margin. And as they're looking at populations to cover and what those needs are, they're offering some of those wraparound supports that actually help keep people healthy or families healthy. So those are our areas, and I think they overlay nicely with what the committee has laid out as priority areas. I would say finally in this area, the one leveler with health insurance or health plans is really that we all get every year to pick a plan. If you know what your needs are and what that plan does a good job at. And I think there is something in that space, and we're looking at it. I think from the previous presentation you heard about data, but data is not information unless it's framed for the user. Lots of reports that are compiled, but if it's not framed so it's useful for decision making, whether that's a person or a nonprofit or a for-profit, it's not really useful. And so I think as one of our priority areas for our department is to actually do a better job in the area of health literacy and making information more useful to the consumer. Turning to slide 6 then, the post-COVID healthcare landscape. In this area, I sort of looked at it from different perspectives, from the consumer and the provider, and then the infrastructure. From the consumer, I think what we saw is really a lot of pent-up need, either not accessing some of, especially screenings and things that because of the pandemic. And so there's been some pent-up demand. Again, shortage areas in most of our state prior to COVID. And so that has been exacerbated, I think, with the pandemic and not getting some screening. I think a positive side that we've seen is really the use and the familiarity with telehealth, and where perhaps providers aren't available in a community, that telehealth and getting the utilization of the instruments and feeling comfortable with getting an outcome from that, I think has been a benefit. With providers, those of you that have been around a long time, most of our state, the federal government, HRSA, Health Resources Service Administration, they do the national assessment of every state and by zip code, really, of workforce shortage areas. Just to reiterate, and not to linger in a problem, but, all of our state is a workforce shortage area for primary care and behavioral health. And so that didn't happen because of the pandemic. We were a workforce shortage area prior to the pandemic. And so I think it just heightens our need to actually be supportive of making improvements in this area. And prioritizing really where we can move the dial. The final area is the infrastructure and ARPA investments. And I was given 15 minutes to do an overview, and I'm not going to do justice really. There's not a forum really. IFC, Interim Finance Committee, is not a forum where these ARPA projects get fleshed out. I will tell you that as an organization, we cluster them differently, and we have a monthly meeting by division looking at where the status is. If you turn the page or the slide to 7, so we actually break them out in category areas. So we have behavioral health, childcare, infrastructure, which are capital improvement projects, and public health, social services, and workforce. To make them meaningful, they really do need to be discussed in that way. I know that, when I think back when we made requests to IFC for these projects, they were coming fast and furious. Some didn't. Some were approved on consent, so they weren't really heard. And the report out is, because it's a finance committee, they're reported out financially. And then, with a driver being how much is left. I would say that of the projects that DHHS has, 45 of our projects are completely finished, and we are de-obligating approximately $10 million. Those projects were completed, but they were completed under what we had requested. There, in total, more than $574 million was budgeted to the department for a total of 148 projects. Again, I think we could provide them as a spreadsheet. I think they become relevant as topics are discussed, like what we're doing. If you sit on IFC, you know that we approached each one with a sustainability plan also. Some were lead-ins to what we intended to have covered by Medicaid, or an investment in workforce that at the very least, we got the outcome of that workforce we invested in. I do believe, as I said previously, there are some initiatives there that are worth us looking at sustaining. And I would tell you on the workforce, I'm looking at opioid settlement funds and how perhaps targeting some of the clinical positions that way to continue them. So I think there's probably solutions in there with braiding funding as it relates to workforce. But I do think worthy of having the discussion of what we saw as outcomes. Probably one of the best efforts that was implemented by Nevada Rural Hospital Partners was the nurse apprenticeship program. And, Joan Hall, who has since retired, stood that program up along with Lisa Sherrick, who was the administrator of DPBH. The nursing board changed their regulations to allow for that program. Slow to start, but boy, once it took off, it just really has been an asset. The outcomes are many of those nurses do stay where they've been able to apprentice, and it supports them in their education. So I think that's one example as we start to look at this with ARPA funding. It really needs to be put in context. I think population focus as well as geography are another way of framing these projects. Happy to provide you a spreadsheet where our spending is, what the status is. I'm happy to provide it in the way that we utilize it, which is clustering in these areas that are shown in the graph, because it just makes it relevant, really, to how we're addressing the problem. And then what all the administrators have made an effort to do is to not have a cliff that we drop off of with services, that to stand something up is an intention if it's working and people are seeing a benefit, to continue it. And so that's our focus as an agency. Our timeline and our opportunities are that we'll do an agency request to the governor, and we have to compete with other state agencies, but that is our process. And so we're doing our due diligence in these areas to have the best outcome possible. And so that would conclude my formal presentation, and happy to answer any questions or
Thank you so much, Director Wickley. I greatly appreciate it. This can be an opportunity for committee members to ask any questions that he presented on, or his team, regarding ARPA funding, just DHHS, or if there's other things that were not talked about, you can ask. You can have the opportunity right now. So, any questions at this moment? Assemblywoman Brown-May.
Thank you, Chair. Thank you, Director Whitley, for your presentation. It's really less of a question and more of a statement. At first, I want to thank you for all of your hard work of yourself and your team throughout the pandemic to bring us here today. But I really want to just get on the record that I would very much like to see the spreadsheet of the existing projects so that we know what's been completed and where we are, especially as you work to deobligate some of those funds, knowing that we do have priorities that we can still address. Thank you.
Thank you so much. Director Whitley, just really quickly, I know we have a question from Senator Titus and Assemblywoman Nguyen, but really quickly, do you know the percentage of ARPA funds that have to be reallocated? Do you have that the number on the top of your head? I know there's some projects that have, and you're going through that process with the IFC, but I don't know if you have a number on the top of your mind.
Hi, this is Debbie Reynolds, Deputy Director of HHS. 30% of the projects, 45% of the projects are 100% complete. This represents 30% of the projects that are overall funded. Were you asking, I'm sorry, about the deobligation?
Correct. So from my understanding, there's a deadline of when the federal government has set on the state that we have to expend those funds. Otherwise, they have to go back to the federal government. So from my understanding, the department right now, because of the whiplash of COVID-19, the IFC allocated funds to certain projects, but they won't be completed within the time frame that the federal government has subsided for us. And so now we have to reallocate to other projects. So do you happen to have what that percentage is? I'm assuming it's a small amount, but I just wanted to ask.
For the record, Richard Whitley, to be declarative, I can tell you with certainty that we're deobligating $10 million from the projects completed. We're currently working with GFO. This is a hard exercise, but we have to make projections, which we've gone through with GFO. They're giving us an opportunity to finalize that we're actually correct, but we have to look at projections. Some projects are easier to do. I would say childcare. Childcare is an area where capital improvements with expanding or construction building to expand capacity, and a workforce piece, because there's workforce shortages there. So those have different timelines and different processes. They're being managed by project for construction, because we don't, if they can't spend it and they had a great idea to expand, but they can't get construction to actually do the building, we are internally, and we just haven't arrived there yet, Senator Donate, so I'm not skirting the question. I just am saying with certainty, $10 million of completed projects are available to deobligate. We are working through with GFO to land on a number where then we would modify our contracts with providers, looking at what they're spending, not just cold cocking them, but actually talking to them and making sure that, so that everyone is informed and that we're moving at the same pace. But it is going to come down to that. And, I have a responsibility for those resources. And I would just say not to spend them, but to spend them appropriately. And if they can't be spent, return them so that they could be utilized for other purposes. And so I'm not skirting your question, but I can't give you a dollar amount, but that we're working on that now with some deadlines to GFO. And it's been clear that IFC wants that from us, and not just our department, but all the departments. So we're doing the work, and we'll have it, and happy to share that with you. Happy to share with you, as requested, the spreadsheet with the status of each project, so that you could be informed on where we're at.
No, that would be greatly appreciated. And I think that the reason why my rationale for that question is if there are certain timeframes that we have to, because of the clawback provisions, that we have to send the money back, but there's still good initiatives that could impact access to care, behavioral health, as we mentioned, then we still need to at least relook at making sure that those projects get funded. I think that was more so my line of questioning, but I think a lot of it can be discussed based on if you can provide that feedback. Let's go to questions in Carson City. Senator Titus.
Thank you, Mr. Chair. Thank you for the great presentation, Director Whitley. I really want to point out what you brought up that we don't hear enough of, because I have brought up multiple times falling off a fiscal cliff and worry about the monies that we brought in from the federal government, that we're giving them to these agencies, and then what happens when it runs out. You brought up an important point today, which I don't think gets appreciated enough. There's also the concern about the services cliff. Not only do we look at it from a fiscal aspect, but you and your departments, and I appreciate this, you're looking at it, what services are going to fall off that cliff. And so thank you for making it more a reality, more human, and less about dollar signs. Because when we can no longer fund these projects, their services are cut. So I really appreciate the distinct difference there, and thank you for putting that in mind. Sitting on both the finance committees and this committee, it's sometimes hard not to see both sides, and so I always look at that. I know our GFO and the Interim Finance Committee has been pushing and pushing and pushing to make sure that we don't send any money back to the federal government, that we make sure that we keep these funds in Nevada. What my question is to you is, when you're talking about reallocating this $10 million, and where there's a time, and there's two distinct different times, one when we have to have them allocated and one when we have to have them spent. So are you looking at reallocating them within your department, or would these funds then be back to be general obligated for whatever, quote unquote, a shovel-ready project is, so we don't lose these funds?
For the record, Richard Whitley, and I should have said that, and I wasn't hiding it or disguising it. I just had too many things in my head, I think. We have put forward some requests of other needs that have emerged. One that's top of mind is Vitality Center in Elko has a treatment facility here in Carson, and the Carson Health and Human Services is not renewing their lease in what was an old rehab hospital. They're using it for Health and Human Services, and those are like 30 treatment beds that would serving not only the rurals, but folks getting out of jail and prison who perhaps could be sustained in recovery, that would go offline. And so that's an example of a project that we have put forward as a request, trying to fit within efforts that we're already doing. And so there are some of those projects that we have put forward that are sort of on the side, but other priorities, or maybe we got it wrong. There are a few projects that just simply could not be executed. It was a great idea perhaps at the time, and I think of the one with APRNs, probably not most appropriate for the Division of Child and Family Services to do scholarships for RN to APRN. It's been a wonderful program, but if I could do a do-over, it wouldn't reside with them. It just so happened that the administrator was a nurse practitioner and came forward with an idea, and it's executed wonderfully. So there are some things that we either had maybe a good idea. Certainly, I think in our spreadsheet we capture that as in terms of some studies that just didn't. We didn't need to linger in the problem longer, and just thought we don't have time. All these require management also, of which we. And I didn't go over the challenges we have with workforce. And, although seeing an improvement with the raises that were given, I think we still are at a deficit in all areas, which includes managing contracts. So, I feel, and I'm probably tough on staff, that if we obligate to a nonprofit, we need to pay them timely and all those things. So there are some projects that simply cannot be completed that will be captured in this also in the spreadsheet. But would be happy actually to provide it and then answer any more detailed questions.
A follow-up, if I might, Mr. Chair. So along that same
Please proceed.
Thank you. Along that same line, you mentioned that you've completed 45 of the projects, correct? So of the other projects, so that 10 million estimate funds coming back are of those projects that are completed, and those were the funds that then weren't used. So I understand that. But when you send us that spreadsheet, I'd appreciate seeing of the other 70% projects that aren't completed. We need to know where we are fiscally on those projects too, and how much money might be coming back, because that seems to me also a huge effort, again, when we're looking at this timeline of making sure these funds are allocated and then spent. And obviously when they're allocated, we would hope that you would have an idea that the money could be spent. And so that's really the key thing. We could allocate money all day long to make sure we meet the deadline, but that one thing about having them spent in a timely manner. So I think that's important. So when you send that spreadsheet, those other ideas and potential monies there would be important to know.
I know that wasn't necessarily a question for the record,
Okay.
Richard Whitley, but I just would say we are doing that. I welcome the opportunity to show our work and the work of the divisions, because that is being done and it is being captured. If the delays are that the child care provider is challenged with getting a contractor for construction, that's captured. So happy to provide that, and it doesn't mean there isn't a need. It just may mean that we can't meet the timeline to complete that project, but we do capture that by project. And I would say we did a briefing to the governor's deputy chief of staff last week, project by project. And so I feel proud of the work we're doing. Never a forum really to present it in. So happy to share our spreadsheet and then answer questions.
Great. Well, thank you very much. It sounds like you've definitely heard from the GFO, and you've actually heard from interim finance from the fiscal point, and then this committee, of course, is now looking at the key components that you said that services fiscal cliff. So thank you very much for that.
Thank you so much. Let's go to Assemblyman Nguyen.
Thank you, Chair. I appreciate the leadership of Director Whitley. It's hard to say you have a 15-minute presentation, because how can you be asked to share content of a 1,000-page book by reading the first page? It's difficult, right? It's hard to sum up HHS in just 15 minutes. I don't think that's possible. So thank you for your effort in kind of sum up some of the priorities. Again, as one of the newer member of the committee, I really encouraged to hear the workforce piece, because the workforce piece is truly the challenge that we have. Not, like you said, you had that issue before COVID, and after COVID, it became bigger, and of course, it changes our thinking, the way that we learn how to see things. It completely changed our game, right? Just looking at the ARPA, since we're on this conversation, and I know that you said earlier that sometimes between IFC and this policy committee, that there is a lack of understanding in terms of sometimes we need to make room to get into the nitty-gritty details so that we can understand, not only as a lawmaker, but also just as everyday people, understanding where HHS is in terms of a lot of these priorities. So I guess I'm curious, because you mentioned a lot of workforce things in terms of all of your priorities and presentation when it comes to access to care, when it comes to the health literacy, when it comes to the education pipeline. That's really awesome and amazing, but I'm just curious that the priority on the funding part, even though workforce is a highlight and a priority, but it's only 11% of the expected expenditure. So I just figure that's a little small in terms of allocating the resources, and obviously infrastructure is a huge concept, and that takes a lot of work, and that's why I see 33%. I agree with that, but I'm just quite curious that if workforce is such a priority, using this one-time funding and setting up this expansion of access, that 11% seems a little low in my eyes. So if you could address that.
For the record, Richard Whitley. I would first address it by saying this is just the Department of Health and Human Services, so, would be interesting to pull workforce out across all the state agencies that have initiatives going with ARPA funding. I think we're a spoke in a bigger hub, so I wouldn't say this is all. And I'm trying to choose my words carefully here. We put forward work programs to spend ARPA funding because there weren't any other, like the example I gave with nurse to APRN. It seemed worthy because, Medicaid had in their budget pay parity. The legislature passed years ago independent practice. There is a workforce that could help us with primary care. UNR and UNLV have their fingers on the pulse of what our state needs are. UNR with a specialty in psychiatry, UNLV with a specialty in pediatrics. So rarely does that happen where the education system, the need, and funding is available. Well, we applied for that, and as I said, from the Division of Child and Family Services, simply because no one else put forward an initiative on nurse to APRN. So there is more work that's needed here, and I think that where those investments are, I think for workforce as well, becomes so important. I think whether it's the apprenticeship piece and it's being able to pay, like uniquely with nurses, with the apprenticeship, they can work to the scope of practice that they've had training for. Nursing board fairly flexible with helping us to stand that up. Not all boards, not all are the same. Social work is a good example of one where this chart doesn't capture really, it's just ARPA spend. But concurrently, we got a federal grant to actually give stipends to supervisors of social work interns. And so there's more story to be told here. This just captures ARPA funding that was allocated by the state for these efforts, but they also need to be put in context because they're categorical funds also being invested in this. And I would say social work is the best example. Social work interns, reimbursable by Medicaid. Employers need to know that so that They perhaps could utilize social workers, but you need a supervising social worker. Well, why would someone take on the burden of having students? We have a federal grant that pays an incentive for supervisors to do that. There's a really nice pipeline there that you don't have to go too far to connect the dots. Worthy, I believe, worthy of probably illustrating something that other clinical disciplines with licensing boards could look at, and what better way to actually promote a discipline that we have a shortage of, we do at the state, than to incentivize the workforce at a community level and with providers. So it's an incomplete picture, both from ARPA and also, I think, with the context of other braided funding that goes to support workforce.
Thank you. Quick follow-up, Chair.
Please proceed.
Thank you. So, and I understand there are constraints in terms of these information being available in a manner that can truly give you the full picture. And then I get that. And I want to make sure that opportunities that we have as a state in terms of having the ability using these dollars, it's not in a way it's a do-over or anything, but it's a way to innovate, a way to modernize some of the things that we do. So I just want to make sure that if we're going to truly prioritize some of these new way of doing things or find a much more efficient way of addressing, I think you mentioned earlier in your comment about, a couple that is experiencing a licensing issue where the timeline might not be the same just because of either data or the way we flow information may not be up to date, right? So looking at the big picture of ensuring that we utilize these dollars correctly and be able to innovate, because this is a good opportunity for us to just bring the state forward in terms of some of the work that we've done so well in the past, and now we have the funding to, do more that we wanted to do and we couldn't do before because of the dollars. So I understand the complexity of all these interagencies working, but hopefully whether it's offline or whether it's accessible through a different access point, that myself as a lawmaker could see some of these innovations, examples, some of these projects that you're doing in a way to address some of these concerns and priorities that you have in a much more detailed manner. I understand today's an overview and that will have some limitation there, but I look forward to learn more about some of these innovations that your team is doing in the state. So that's just my request. Thank you, Chair.
Thank you so much. Any other further comments or questions? Is that Assemblyman Gray? Do I see a hand? Please proceed.
Yes, Senators, thank you. I'm going to go a little bit sideways here, but I want to get this out while it's still fresh in my mind as we're addressing shortages, especially in the social work arena. I think one thing we need to look at, and there was a BDR last session that addressed the social work compacts. 2 states have passed it. Our next door neighbor, Utah just passed it. There's some 20-odd others looking at it right now. And I mean, if you look at that, if we were, to enter into a compact like that, that would address some of the need in, say, West Wendover, things like that. So I'm hoping, Senator Doniati, that we could use one of our BDRs to maybe bring this back and take a look at that. And, it's I won't say it's new or fresh or innovative, but I think it is new and fresh and innovative, at least for, for us. Something that we should use to plug some of those holes. So just wanted to get that out there. Thank you.
Thank you so much, Assemblyman. If you can send us the mock language, I'm sure we can slate it for the agenda when we talk about the behavioral health days.
I will gladly do that for you,
all
sir.
right. Thank you. Any other feedback or anything else? Seeing none, we'll go ahead and close this agenda item. Thank you so much, Director Whitley. And we'll move on to the next one, which is item 7, updates from Nevada Medicaid. With us, we have Ms. Melinda Southers, who is the Deputy Administrator for the Division of Healthcare Financing and Policy. And please begin when you're ready.
Good morning, Mr. Chair and members of the committee. My name is Melinda Southard, and I am a Deputy Administrator for Community Supports and Engagement in the Division of Healthcare Financing and Policy. I also have with me Deputy Administrator Kelly Cantrell from the Division of Welfare and Supportive Services, as well as other deputies from both our divisions here in the audience and in Carson City to help answer any questions of the committee after our presentation. Also, my administrator, Stacy Weeks, asked me to send her regrets that she was not able to be here with you all, and I do want to thank you for inviting us to present today. As you can see, we have a very full agenda today. Before we dive into more specific updates, I would like to give a quick overview of Nevada Medicaid, then a recap of the legislative activity from last session impacting the division, as well as updates on some of our major projects listed here. And last, of course not least, Deputy Cantrell will be providing an update on the public health emergency unwind with respect to eligibility redeterminations for Nevada Medicaid. As committee members may recall, like all states, Nevada Medicaid is overseen by the Centers for Medicare and Medicaid Services, or more commonly known as CMS, at the U.S. Department of Health and Human Services. Every state must have a single state agency responsible for the functions of their Medicaid program, which for us is our Department of Health and Human Services. The functions of the single state agency for Medicaid in Nevada have been delegated by the director to two divisions within the Nevada Department of Health and Human Services. These are the Division of Healthcare Financing and Policy, also known as DHCFP, and the Division of Welfare and Supportive Services, which is also known as DWSS. DWSS oversees the state's eligibility and enrollment systems and outreach programs for Medicaid, along with the state's appeals process for recipients regarding eligibility determinations, while DHCFP oversees the coverage side of the program. This includes the budget and financing, provider enrollment and payment, program integrity activities, appeals and hearings for provider and recipients on coverage, audits, and the development of benefits and rates. At DHCFP, we also oversee the benefit delivery systems, which include both the managed care program and the fee-for-service program. From a Medicaid recipient standpoint, DWSS is the point of contact for enrollment, really acting as that front door to the program, ensuring all those enrolled are eligible. Once the recipient is enrolled, DHCFP, or its contracted managed care plan, becomes the recipient's main point of contact for coverage and access to Medicaid benefits. Providers also work with DHCFP, or the contracted managed care plan, for billing and payment when serving Medicaid recipients. Since July, DHCFP has been working hard to implement 52 bills that were passed and signed into law last year that directly impact Nevada Medicaid. 2 of these bills require the division to update regulations under the director's regulatory authority. 39 require system updates in our MMIS system, and that's our payment and claim system. And over 22 state plan amendments and policy updates are required as a result of this new legislation. This is all in addition to over 20 other major projects Nevada Medicaid has underway. Many of the bills passed last session require the division to seek and receive federal approval before fully implementing program changes. Thus far, we have received federal approval of many of these requested changes. And I want to note there are a few updates I'm going to provide on this slide with regard to the dates. So first, here we have the Applied Behavioral Analysis, or ABA rate increase. Next, we have the dental rate increase, which I do have a correction here, that this approval is retroactive to January 1st of 2024, not July 1st, 2023. Another quick clarification here, a retroactive date approval means that providers who already billed for days of service from the retroactive date through the date the change was approved will not need to resubmit those claims, as they will be reprocessed automatically to reflect the new rate paid to the provider. We also have a rate increase for both residential and assisted living providers. You'll note that assisted living is separated on this list, but the rate increase here includes both of these provider groups and is retroactive to January 1st of 2024. The rate increase for residential group providers has been implemented, and the rate increase for assisted living providers is set to implement on February 20th. Rate increase for home health and private duty nursing providers, noting another correction here, that system updates have since been implemented, and this approval is retroactive to January 1st, 2024, not July 1st, 2023. Additionally, we received approval for our personal care attendant, or PCA, rate increases, providing another update here today that these system updates have since been implemented. We also have gender dysphoria coverage for adults, physician rate increases effective January 1st, and advanced practice registered nurse and certified nurse midwife rate parity increases effective January 1st. Also, I am happy to report that just last week, we received federal approval of the bill expanding the types of providers able to supervise community health workers. After approval, the next step is to ensure the division's MMIS system, or our payment and claim system, is updated to reflect program changes in payment or coverage. This may take a few additional days or weeks, depending on the size of the change. On the other hand, we have a handful of bill implementation requests that are still pending federal approval and review. Some of these include requests for postpartum care coverage expansion to 12 months, skilled nursing facility rate increases, and on that we are requesting a retroactive date of January 1st of 2024. Also, a unique reimbursement rate for specialty clinics for cancer and rare diseases, rate increases for providers of service to people with intellectual disabilities, the personal needs allowance bill, and the dental coverage expansion bill. Committee members should have also received a handout of the public stakeholder presentation the division held last month, which includes more detailed information and updates on the over 50 bills that the division is actively working on. In addition to state plan coverage updates, the division has several waivers it is required to seek and implement under state law. The first one is the state's Section 1115 waiver to permit Nevada Medicaid to draw down federal funds to help cover the cost of substance use treatment for adults in residential settings, also known as institutions for mental disease. The state received federal approval for this waiver on May 24th, 2023, but was not able to fully implement the payments until it received federal approval of the implementation plan, which we did receive on August 1st of 2023. The division is currently awaiting federal approval of an updated payment methodology that will improve payments to these residential providers under this waiver. Additionally, the division is working to implement legislation from the 2021 session, which includes seeking additional federal authority to cover the cost of treatment in residential settings for adults with serious mental illness. The division hopes to submit this waiver amendment later this year for federal approval with an effective date of January 1st, 2025, pending CMS's review timeline. The third item on this list is from another 2021 bill that required the division to seek federal authority to cover dental services for a segment of the adult population with diabetes when treated in a federally qualified health center. The waiver is still under review with CMS, and the division is involved in answering various questions from CMS regarding this waiver at the current time. Lastly, the division is in the very early stages of planning for a new 1115 waiver submission. This waiver is the result of Assembly Bill 389, which requires the division to seek new federal authority to allow the state to draw down federal matching funds to cover services for individuals who are incarcerated up to 90 days pre-release. The division recently secured a list of vendors to support its waiver activities and is working to identify which vendor is going to best support these efforts. We plan to establish an advisory committee across multiple stakeholders and agencies impacted by this waiver, including DWSS, Department of Corrections, counties, jails, our managed care organizations, and several others, with an emphasis on gathering engagement and feedback from those with lived experience, as this is truly a community conversation requiring that cross-system collaboration. Before we move on, I did want to note that CMS has reported up to a 5-year wait list for certain 1115 waivers. Administrator Weeks is exploring ways to reduce this timeline, one of which includes asking the National Association for Medicaid Directors to work with CMS on strategies to simplify or streamline the waiver process at the federal level. In January of this year, the division implemented the new private hospital provider tax and payment programs. This slide provides an overview of the various activities since lawmakers last convened during session. As you can see, the division conducted the required survey of hospitals and received the necessary votes to move forward with implementation. This included seeking federal approval of 3 new Medicaid payment programs to supplement payments made to private hospitals in the state of Nevada. In mid-December, CMS approved all 3 payment programs. This includes approval to pay new supplemental payments to private hospitals retroactively back to July 1st of 2023 with respect to claims paid through the state's fee-for-service program. For the first 2 quarters of this calendar year, the division is applying a ramp-up period to avoid cash flow issues for hospitals with 4 assessments and 4 payment cycles. To date, the division has issued 2 tax invoices and completed a full payment cycle to complete fee-for-service payments made to private hospitals. The second payment cycle is scheduled to be sent to hospitals on February 23rd. Starting July 1st, 2024, the division will end this ramp-up period and will issue invoices and payments once per quarter. The total new Medicaid supplemental payments made to hospitals are reflected in this chart, with approximately $552.6 million to be paid in SFY24 and a projected approximately $927 million in SFY25. As a reminder, these new payments are made up of 2 revenue streams, one of which is the new tax revenue paid by all private hospitals, and the other is the new federal Medicaid funds the state is now able to draw down to match the tax dollars. The provider tax revenue makes up a little over 1/3 of the total new supplemental payments made to private hospitals. Along with the implementation of the provider tax, our team has been working hard to prepare for the rollout of statewide managed care in 2026. To gather feedback, the division visited all rural hospitals this past fall and released a request for information to gather information from stakeholders on the upcoming procurement. Some of the common themes raised by stakeholders for consideration included the need for greater use of telehealth in provider networks, improved access to reliable, non-emergency medical transportation, new strategies to address significant gaps in the state's healthcare workforce, and solutions to the state's behavioral health crisis, especially in rural areas of the state. To support the development of the Request for Proposals, or RFP, the division contracted with Manat Health Strategies earlier this month. We are currently aiming for a release date for the RFP sometime in October of this year to ensure enough time for the contracting process and any necessary system updates. The next public workshop on the statewide expansion of managed care will be held on February 22nd at 3 p.m. The expansion of managed care will impact about 75,000 rural Nevadans. We have recently updated the numbers here, so when we look at today's population, managed care serves about 72% of the population. This expansion is anticipated to increase the portion of the population served by managed care by about 10% or less. This is because the Medicaid expansion does not include all individuals enrolled in Medicaid. Instead, the managed care expansion only applies to adults without children up to the age of 64, children who are not in the welfare system, and parents or guardians up to the age of 64. Other populations across Nevada will remain in Medicaid fee-for-service, which includes those listed here on the slide. I also want to note that tribal populations will remain a voluntary managed care population, meaning once enrolled in an MCO, they can request disenrollment to fee-for-service at any time. Another important effort we've been working on with managed care plans is increasing the use of value-based payment design in the state's Medicaid program. By using more value-based payment models with providers and plans, the division aims to gain better value for the taxpayer dollar. This effort includes tying payments to value and quality rather than only volume, like fee for service, and rewarding providers and plans for improving outcomes and increasing efficiency in the system, which includes lower costs. Right now, the division is focusing on several initiatives that aim to advance the use of value-based payment design. The first is a new hospital and health plan collaborative on using value-based payments to improve quality and outcomes. This initiative will begin later this year. The second is a new bonus payment program in the managed care program that rewards plans for increasing spending on primary care services and for conducting certain public health campaigns to improve prenatal and postpartum care. The last effort will begin later this year when the division begins developing its new procurement proposal and budget concepts for next session. This includes developing certain state models for value-based design that will work across all plans in the state's Medicaid managed care program with consistent metrics and requirements. Last, but again, of course not least, is the state's new all-payer claims database, or our APCD. The division recently collaborated with OnPoint Health Data to develop the state's new APCD program over the next 12 months. The division also received federal approval in December of last year for enhanced federal Medicaid funds to help support this effort at a 90-10 match. Regulations related to the APCD are currently in the process of being finalized, and the division anticipates hosting a public workshop in the coming months prior to submission of regulations to the Legislative Council Bureau. More information about the APCD and this process is available on the APCD website listed here. And with that, I will turn it over to Deputy Kelly Cantrell to discuss the Medicaid Unwind process. Thanks.
Good morning. For the record, I'm Kelly Cantrell, Deputy Administrator with the Division of Welfare and Supportive Services, and I'm just going to talk to you very briefly this morning about the unwind. So in the middle of last year, the Medicaid unwind from the public health emergency started. And what that means is that for the first time in 3 years, individuals who are no longer eligible for the program or who failed to turn in their renewal packet could be and were terminated from Medicaid eligibility. 3 months after we started the unwind, we received policy clarification from the federal government letting us know that the way we were doing renewals was no longer an appropriate way of doing them. And so we moved into reinstating about 114,000 individuals and putting them back on Medicaid until we could meet the requirements of the new policy clarification. 3 months after that, so in January of this year, Nevada was able to restart eligibility redeterminations. And once again, individuals that don't turn in the renewal packet or who truly are not eligible for Medicaid are terminated and lose their Medicaid coverage. The unwind in the state of Nevada is expected to end September of 2024. So we're right in the thick of it. So what does that look like? So in the beginning of the unwind, less than 30% of individuals were able to be renewed using our automated renewal process, which you'll hear called ex parte. The ex parte process uses electronic data sources and can renew individuals without any intervention from a worker or without the need for the customer to return a renewal packet. But due to system enhancements and flexibilities that we've been allowed through waivers, since renewals have resumed, that number went from 30% of individuals being ex parte to 69% of all individuals being ex parte. And again, that's without the need of any worker intervention or mailing out a packet to our customers. 69% are ex parte, and an additional 18% are turning in those packets that we send through the mail, and they are continuing eligibility based on their own efforts. So what that means to us today is that 88% of all Medicaid renewals that are due are turned in and are renewed and are found to be eligible. This is huge because I just want you guys to know that prior to COVID in 2019, 31% of all Medicaid individuals were terminated for failure to provide that redetermination packet. And this is historic. This is a historic high. We have a historic number of people retaining Medicaid eligibility and retaining that continuity of care. And we fully believe that it's due in part, if not entirely, to the collaborative efforts and the outreach efforts that have been between the Welfare Division, Nevada Medicaid, the Health Link, Nevada Health Link, providers, community partners, and together we are now only terminating 12% of all Nevadans off of Medicaid. So those are my brief comments, and Ms. Southard and I are here to answer any questions that you might have. Thank you.
Thank you so much. Are we good to proceed? Good for questions? All right. So I have a few, but I know probably everyone does. So I'll let other folks go first. Let's go with Vice Chair Ornlicker.
Yeah.
Oh, and really quickly, I do have one quick comment. There's a reason why. So I asked Medicaid to include this in their presentation items. There are specific things that I wanted to make sure that we are aware. Same thing with some of the bills that we pass, so we can understand their workload in the interim. There was one that obviously was left off. I would ask that we do not, we refrain from asking questions related to the public option, because we will be coming back to that towards the end of the interim in a different meeting. So this item for presentation and questions should be solely focused on the items that they have presented. If we can please keep our comments to that. Thank you. You may proceed.
Thank you, Chair. I just want to pick up where you left off. So congratulations on the 88%. That's great. I wish all my students would be at least at that level. I'm interested in another statistic. Historically, there have been problems with people who are eligible for Medicaid but don't enroll because they're not aware of it. It's complicated, whatever. Do you have a number on that, where we are? Have we been able to close that gap on making sure people sign up in the first place as opposed to renewing?
Thank you for the question, Kelly Cantrell. For the record, I do not have those statistics available with me. We do have that, I believe, on our dashboard, and we could get that information back to you. But I will say that the Division of Welfare has an unprecedented targeted outreach partnership group, and what it is a team of individuals who work out in the community. They don't work in a traditional welfare office. We are actually in 196 outreach sites, sites that are criminal justice, medical, social services sites, like dental schools, jails, and we go out into the community to meet the people where they are, excuse me, to break that stigma of someone having to come to the welfare office. And so there's extensive outreach to get people on our programs. We also will do events where we'll go to, one of the events I can think of offhand, we went to a Latin grocery store. We set up tables. We dressed everyone down in blue jeans and t-shirts, and we talked to them about, hey, are you interested in any programs? Do you need food stamps or medical? And it was a very informal meeting people where they are setting. So I think that we try and do a very good job of reaching out to individuals where they are to try and close that gap.
Thank you so much. Assemblywoman, do you have a question? Go for it.
Thank you, Chair. Thank you for the presentation. It's a lot of very detailed, really great information. Congratulations on the progress being made. My question is relative to the PCA rates. That is what I get most often in my inbox. I have moms of adult children who have significant needs, and the personal care services that allow them to go to work, right? So there's been a delay in the implementation and the rate increases. You just reported, though, that we have now been implemented. Can you talk a little bit about that? When did that take effect? And why did we not go back to July 1 as opposed to that January 1, 2024 implementation date?
Melinda Southard for the record, to Chair, through you, to Assemblywoman Brown-May. So thank you so much for the question. I know that our team has been working really hard to get that implemented, and as I had mentioned, if we have the retro effectiveness back to the January 1st date. However, I cannot speak to why we chose January 1st over July, so defer to any of my colleagues in Carson City who may have that information. Thank you.
If it's helpful, probably we can, I'm not sure if there's anyone in Carson City that can answer it, but if not, then we can obviously have the Medicaid come back and provide us a response to that, if that's fine.
Thank you.
All right. Do you have another question?
That's it. Thank you.
Anyone else down in Southern Nevada? Let's go to Senator Titus.
Thank you, Mr. Chair. And again, thank you for the presentation and especially the update on the unwind. I get a lot of questions regarding that, and it's been in the news a lot. And I appreciate the fact that you as an agency, we as a state, weren't trying to just kick people off Medicaid. There was a process, and when you had that setback, it was because the Fed said, hey, you need to do it this way. And moving forward, some updates on that. My question revolves around the application. A good job in getting 88% of those returned. I'm very impressed with that, actually. I have been at this in the past, and just the accessibility, getting those applications returned. And a lot of folks that are on Medicaid may not have a home, may not be able to get to the post office, may not be able to return those. And just wondering if you're continuing that collaboration at different sites, like say the food bank, where folks come in, and I know you can apply for SNAP, you can apply to different things. You're continuing the kind of being at those particular locations. I think I heard you say you do set up and you went through different, maybe a different a Hispanic location of some sort. I'm not sure what, that you were there present. Are you continuing that also here in the north and making sure that you get out there in the community to make sure that all those that are eligible indeed are getting signed up for it?
Thank you for the question, Kelly Cantrell for the record. Senator Titus, yes, we are definitely in the north. We're in the rurals. If we can't service a site with someone in that actual location, we do service sites, especially some of the rural sites, virtually. So I rattled off a couple criminal justice, medical, social services, but we attend health fairs. We do tribal health fairs. We're in behavioral health clinics. We're in libraries. We go to back to school nights. If you can think of it, we've probably been to an event or we're in an area where people are. We get requests for these all the time. I've got, in fact, my wait list right now for community partners is 86. There's 86 more sites that want our people there, and due to staffing and what it takes to get this stuff done, it's hard. But we're even in Safe Nest, like we're in domestic violence. We go as many places as we possibly can and cover as much ground as we can. And yes, we are looking to grow that program. It is definitely something that's on our mind every day. And I feel like the more we could grow, the more we could reach people. So yes.
Thank you. Another question, Mr. Chair,
Please proceed.
So also in the news recently, we see some concerns about people who are like dual eligible for Medicaid and Medicare. What kind of setup do you have for that? Because it's becoming more of an issue of folks that really do qualify for both, and somehow they get lost in that.
Kelly Cantrell for the record. So we do also service individuals that are Medicare and Medicaid eligible. There's programs where we will pay for, they get Medicare for their medical appointments. We will pay for the premium, the Medicare premium. We will help with co-pays and stuff like that for Medicare individuals. And that's done on a tier basis. So the higher the income they have, the fewer things are covered, but we do work with Medicare and Medicaid patients both. So it's something we've done for quite some time.
Thank you for that.
That answers your question.
Yeah, it's kind of broadly it does. The proof will be in the pudding, though, and how easy it is for folks to actually do that. Final question, if I might, Mr. Chair. You mentioned the dash, about people applying the dashboard. How easy is it? Where do we go for that website? Because what I'm looking for, and question would be on your dashboard, the number of current, and I know this is a moving target, number of folks that are on Medicaid now versus the number that were on pre-COVID. And so do you have that type of number, those type of numbers on your dashboard? And if so, what's a quick, easy access that we can go to find that?
Kelly Cantrell for the record. Yes, ma'am, we do actually have those numbers on there. The dashboard is accessible through the Office of Analytics, but you can get there through the Director's Office website, and then it is accessible through that. We can make that link available to you after this if you would like for that to be a little bit easier. But I will tell you, we were right around 950,000 Medicaid recipients at the height of the pandemic, and right now we're right at about 884,000.
And what were you before the pandemic?
600, Kelly Cantrell for the record, 650,000.
Great, thank you.
And those numbers are averages.
Great. And then if you would please make that, because having to go through one website to go to another website to go to another website to get to the dashboard, it would be nice if I could just go to the dashboard.
Kelly Cantrell for the record. We'll get that link over to you.
Thank you. Thank you, Mr. Chair.
Thank you so much. Any other questions? I'll do mine really quickly. So I want to talk about the assessment and payment schedule. First of all, I think it was impactful that the providers for the hospital assessment came together for this good initiative. Do you by any chance have a breakdown of how much each hospital is going to be getting in terms of new revenue for the next projected 2 years? Is that something that you guys have already?
Melinda Southard for the record. I'm going to defer to Lynette Aaron in Carson City.
Hi, good afternoon. For the record, Lynn Aaron, Division of Healthcare Financing and Policy. Yes, we do have that information and we can provide that offline.
Great, thank you. I think it'd be helpful just for the committee members to understand how much new revenue is going to be projected and, of course, through the federal matches that we have coming in. The next question that I have is on the value-based payment design program. I know that there's a bonus program tied to for participants in managed care. You know, I talk to a lot of physicians that they just don't want to deal with MCOs. They don't want to deal with HEDIS measures, et cetera, but it's probably just because of how complicated it is, and they just stick straight to fee-for-service. Are there options, or are you guys thinking of incentives to help providers that maybe are independent, but they just don't have the capacity, but they're interested in helping follow quality metrics, but they don't participate in other programs? Is that something that you guys have come into consideration to help those small physicians that just need a little bit of support to help their patients receive better access to care?
Melinda Southard for the record. Thank you for the question. Yes, absolutely. The division is happy to work with all providers to determine how we can, mitigate those gaps and help break down the barriers to access to care for folks, and just really wanting to engage with them in a conversation and work with them. Yes, thank you.
Thank you. And then the last conversation is with the public health emergency unwinding. Walk me through some of the outreach processes. I know that you mentioned that you have you've situated yourself in making sure that you're in a community, that you're presentable and accessible, not intimidating, etc. But I think there's oftentimes there's planning, and then there's like the implementation of it. And working in the healthcare space, we see that outreach can be incredibly difficult, right? Especially if people are transient and they listed an address, but their address isn't exactly where they live. And we as government officials will send out government notices saying, hey, you need to fill out this form, but they might not even receive it in the first place. And we have found it incredibly difficult for even reaching out to folks who are perhaps experiencing homelessness and so forth. And it's incredibly complex even to reach those populations for healthcare delivery. And so what other processes outside of just going to grocery stores do you guys have in place? Do you have a door-to-door knocking program? Are you going out to those communities? Are you calling them several times before you unwind them? Like, just walk me through that process if you can.
Thank you, Chair. Kelly Cantrell for the record. I think Melinda and I will share in answering this question for you. So our outreach, I will say the homeless population is indeed hard to reach. And we have, I want to say, and this isn't a guess off the top of my head, I believe we have 9 people that actually sit at the courtyard to help service some of that homeless population. when our people are out in the community, they have what we call an office in a box. So they have everything they need to literally hand a food stamp card over. If someone applies for food stamps, they can hand them that card over so that they can access benefits and not have to go to an office to get that part of it done. So it's very robust. It's very organized and efficient in that regard. And we do, in conjunction with the HCFP, when a renewal is due, multiple people are notifying the individuals to let them know. Not just Division of Welfare, but DHCFP, they text everyone. So when the renewal is coming due, they send a text message. The pharmacies, the pharmacists have been made aware of lists of when people, and the doctor's offices, and they're saying, hey, make sure you watch your mail, make sure, or do you know that your renewal is done, because that's stuff that they can see. I'm not sure if Melinda would like to add anything to that, but I'm going to stop there.
Sure, Melinda Southard for the record. So we do also have tear-offs that we've distributed to several providers that's, saying if you've lost your coverage, here's a quick, how to gain that access back. And as Deputy Cantrell noted, yes, we do have our Medicaid app that we text recipients and, listservs and several notifications that we try to get the word out as best that we can. But, just doing our best to reach everybody. Thank you.
I have a follow-up question, and I know Senator Titus has one more. I think about data and metrics, and obviously we have our dashboards, but I think what we see nationally, and Nevada is not the only one, right, is oftentimes when we have these departments and organizations by nature of just organizing things, there are departments that collect data that don't work in conjunction. And so are there opportunities that you see perhaps in partnering with, say, like the Nevada Department of Education, whereas if parents are filling out forms for free and reduced lunch, like that can be a trigger to making sure that we're connecting the dots and we're working together across departments? Is that a conversation that has existed? Is there work being done, or do you need an infrastructure to bring that together? It's more of a, how connected is our data points that we have across our government system is probably the better way of phrasing it.
Melinda Southard for the record, thank you. Yes, we have an excellent collaboration with the Nevada Department of Education. We also work with them very closely in our school health services program, as several school districts are able to request Medicaid reimbursement for authorized services provided in the schools. And so we are very connected with them in that way. And we've talked about, how can we do better communication to the parents through their flyers and things that they send home with the children. So definitely collaborating with them, and looking forward to collaborating with several other state agencies, especially as we work on these other projects, say as related to, the Assembly Bill 389 and the 1115 waiver there, and connecting with the other state agencies in that way. So really open to the conversation. Thank you.
And just one more clarification. Has there been any questioning in terms of, for the folks that, as part of the unwinding, that now you are going to be disenrolled because you didn't submit your paperwork, et cetera, has there been any post follow-up upon that? And I'm assuming a lot of them are, I got a job, I already have health insurance, I don't need Medicaid anymore. Obviously, some pass away, some of them move away, and so forth. So is there any metrics that our state has gathered post-unwinding to try to make sure that those folks, like that it wasn't a mistake, essentially? Explain to me what some of the efforts have been from the division on that.
Melinda Southard for the record. I was going to defer to Sandy Rubelit in Carson City.
Good afternoon, Sandy Rubelit. I'm a Deputy Administrator with the Division of Healthcare Financing and Policy. I just would add, part of our outreach also did involve the managed care organizations doing direct outreach, because they're very motivated to keep their members. They don't want to start over. So that was a key factor. We are not currently gathering or surveying members as to why they're falling off the rolls. Some states are doing that. We just don't have the resources at this time to perform that type of outreach. But I would add, and maybe Kelly could explain the reapplication process. So if you do fall off, you have a period of time that Kelly can explain that to get back onto the program.
Kelly Cantrell for the record. So historically, about 35% of individuals who fall off reapply. And if anyone reapplies within 90 days of being terminated, they can be made eligible back to the date that they originally lost coverage, so there's no gap in care at all. Like I said, our applications are available everywhere. They're online. We've got people out in the community. People can fax. I know, Senator Donyate, you asked earlier about getting applications to us. They can do it over the phone. We take applications over the phone, fax, online. There's just a myriad of ways that they can get to us. But there is about 35% people who fall off do end up coming around. And like Deputy Rubel said, we don't track the metrics yet of the individuals who fall off and then we don't ever see them again. We know a portion of them, though. We refer directly to Nevada Health Link, so the Silver State Exchange. So if they're over income truly, they go there to see if they can pick a plan that starts as low as $30 a month. So we don't lose, we know that that's happening.
Thank you. And the reason why I'm asking these questions is I think it's more my personal perspective. I want to dive deeper into what was alluded to, which is we can have resources in place to help with that post-analysis. We just don't have them yet. And so I want to make sure that I empower you guys to determine what resources you need to get that point. I don't think trusting the MCOs, and I need to mind my words carefully, I don't think it's enough to just say we're going to let the MCOs do this, because by very nature of how the market works, if someone is a high utilizer and they're high risk, is there a return on investment for them to keep them on? I don't know, right? So I think it's just important that we make sure that we are keeping folks updated, that we're not letting people fall through the trenches, and that we have an obligation to protect the people, and whatever resources you need to make sure that that's being done adequately, then I want to make sure that we as a committee empower you to do so in partnership with the MCOs, right? I want to make sure that they also have the resources as well. And so I just want to make sure that I had that clear. Senator Titus, I think you have one more last question, and then we have Dr. O, and then we can go to lunch.
Okay, great. Well, I hate to be in between everybody and their lunch, but I asked the question earlier about the number of people that were enrolled pre-COVID, post-COVID, and then currently. But I also meant to ask, and it's been a question that I've raised in the past, is when we expanded who could receive Medicaid and services, I alluded that it was very much like giving everybody a free bus pass, but not any new buses. Because just because you have insurance doesn't mean you have care. And one of the conversations here is this access to care, because we don't have enough providers. So there is a question here. One of the numbers that I would like to know, and if you can't get it to us now, that perhaps when you give us all this additional information we've asked for, you could include it. But what was the enrollment of providers along that period of time? And so what is the current enrollment of providers? Have you increased the number of providers that will see Medicaid patients? Because I, in my practice, would see whoever walks through my door, but then getting them to the next level, the next specialist or whatever the treatment, that was always the barrier that I face. Not necessarily getting into their primary provider, but it's subsequently their treatments. And so I'd be very interested to know if Medicaid has truly expanded the possibility of providers and who they are. And I know it's up a lot to the MCOs, who they have under their, who they've contracted with, but it really makes a difference being able to go see somebody, not just have that insurance. So if you don't have that now, I'd like to see it in the future. Thank you. Thank you, Mr. Chair.
To you, Chair, through you to Senator Titus. This is Melinda Southard for the record, and we would be happy to get that information for you. I apologize I don't have it with me today, but definitely will follow up. Thank you.
Thank you.
Thank you so much. Vice Chair Ornlicker.
Thank you, Chair. I have a question about that really terrific increase in funding through the hospital provider assessment. And this answer may depend, you may not know all because of the managed care role, but what I'm curious about is with the increase that you'll now be able to implement for reimbursement, do we know now how reimbursement will compare to other important benchmarks like what Medicare pays, what their actual costs are, what private insurance pays? Do you have a sense of how our reimbursement will compare to those other benchmarks?
Melinda Southard for the record. I defer to Lena Aaron in Carson City if she has the answer. Thank you.
For the record, Lynette Aaron, Division of Healthcare Financing and Policy. I'm sorry, can you restate the question?
Sure. With the increased funding from the hospital provider assessment, reimbursement rates will increase for hospitals. And how will their new reimbursement rates compare to other benchmarks for their reimbursement, whether actual costs that they incur for care, what Medicare will pay them for the same service, what private insurance will pay for the same service? Do you have that kind of information, which I know can be complicated with managed care plans as intermediaries, but do you have a sense of that?
I think we'll have to take that question offline just to make sure we can capture all of the questions you have regarding that, and maybe want to go into detail into like the specifics that you're asking for.
Great, thank you so much. Any other final questions? All right, we'll go ahead and close this presentation item. Our committee will be taking a quick 15-minute recess so folks can grab something to eat, get a drink of water, and then we'll be back with our two presentations. We have another one on tribal health, and then we have a last one on rural health. So we'll do those when we come back, and we'll take a recess for 15 minutes. Welcome back, everyone. We are making our ways to our chairs, and folks are coming back to the committee room. We have 2 more agenda items. So, fun fact, I had allocated the meeting to end by 2. I think we might be able to get there beforehand, but it all is on the premise that we work together and we get this done ahead of time. So, we do have 2 presentation items, and so I want to make sure that we have adequate time to ask our questions and go through this process. We have, the first one will be on rural health, and the second one will be on tribal health. So let's go to agenda item 8, a presentation on hospital-based rural health care in Nevada, needs, challenges, and policy considerations to improve access to rural health care services. And for this one, we have Mr. Blaine Osborne, who is the president of the Nevada Rural Hospital Partners. So please proceed when you are ready.
Thank you, Chair Dignate and members of the committee. I really appreciate the opportunity to be here and help you all kick off your interim work this session, this interim. So first, I want to talk a little bit about the makeup of our, Blaine Osborne, President of Nevada Rural Hospital Partners, for the record. Thank you, Senator. So first, I want to talk a little bit about the makeup of our hospitals. None of you are new. I think you all know us pretty well, so I'll just go over that briefly. Then I want to talk a little bit about some of the priorities that we got past the last legislative session and where we are in implementing those items. From there, just want to touch a little bit on some of our challenges and needs as we start looking for ways that we hope the committee will be able to support us next session. Nevada Rural Hospital Partners is a consortium of the 13 critical access hospitals in the state. That is every rural hospital in the state except for Elko. Elko is a little bit larger, not a critical access hospital. Affiliated with our 13 critical access hospitals are 18 rural health clinics. Of our our critical access hospitals, 5 of them are corporate owned. 7 are county hospital districts, meaning they are governmental entities. These are governed under Chapter 450 of the NRS, and they receive limited tax support. Of the 13 critical access hospitals, 7 operate a distinct part long-term care unit. That's often the only long-term care beds available in those communities. Earlier today, there was a certificate of need hearing by the Division of Public and Behavioral Health for support of a project that Barton Health is doing. For those that aren't aware, Barton Health is moving their hospital, or intending to move their hospital from their current location in Southern California, or in southern Lake Tahoe on the California side, across the border into Nevada. So that project is underway. They had their certificate of need hearing today. We'll see what the results of that are, but they are expecting to be able to open a hospital there at State Line as soon as 2029. Additionally, there's communities in the state of Central Lyon, West Wendover, and Tonopah that are all interested in opening hospitals. We passed a bill last legislative session, AB 277, on rural emergency hospitals. And we think that that is a really good model that is a solution perhaps for some of those communities if we can get some congressional changes. We talked about it during the legislative session. Currently, to become a rural emergency hospital, you have to be a critical access hospital and convert to that. So you have to be an existing facility. It's not open for new facilities to start. But we're hopeful that a congressional fix can be made to that, and that might be a really good model for some of those communities, Central Lyon, West Wendover, perhaps Tonopah. Additionally, I just wanted to provide everybody with our just the average payer source in the emergency departments across our rural hospitals. Currently, the average payer mix is 30% Medicare, 30% Medicaid, 12% commercial insurance, 10% self-pay or others, and 18% other types, Indian Health Service, VA, workers' compensation, those types of insurance products. Financially, all of our critical access hospitals are recovering very well from COVID. And what I mean by that is we hear a lot across the country about the rural hospital closure crisis. And I am happy to say that none of our critical access hospitals in the state of Nevada are on the verge of closure. Later in the year, I hope to be able to report back on the status of Senate Bill 241, which we passed last legislative session, which should even make the financial position of some of those county hospital district hospitals even stronger. If any of you are interested in more statistics on any of our rural counties, rural hospitals, I'd refer you to the Nevada Rural and Frontier Health Data Book that is published by the Office of Statewide Initiatives at the University of Nevada, Reno School of Medicine. So last session was really wonderful for our critical access hospitals, and I want to thank you all for your support of our initiatives. Some of the big items for us, as I mentioned, Senate Bill 241. Senator Titus brought that bill for us, and we appreciate that. That allowed cost-based outpatient reimbursement for our critical access hospitals and cost-based swing bed reimbursement for those that have swing beds. Currently, and Ms. Southard went over this in her presentation earlier, the Division of Healthcare Financing and Policy has drafted a state plan amendment. There is a public workshop coming on that at the end of March. We expect that to be submitted and approved by CMS by probably the beginning of June. And then that reimbursement will be made retro back to January 1 of this year. Additionally, and kind of in conjunction with that, we talked a little bit about the provider fee program. The provider fee program, we appreciate the changes that were made in Senate Bill 435. And as you heard, those first assessments and distributions have been made. Again, I want to be clear, though, that that is just for the private hospitals in the state. So of that, those are 6 critical access hospitals participating in the provider fee program. Those county hospital districts, those public hospitals, are not included in the provider fee. Mentioned AB 277 for rural emergency hospitals. Currently, the Board of Health is tasked with doing regulations on that, so we're hopeful that those will be passed in an upcoming Board of Health meeting. Another initiative that we spent some time on last legislative session was certified registered nurse anesthetists. Senate Bill 366 was passed and has been implemented by those boards, which has ensured there's no disruption to anesthesia services in our critical access hospitals. Lastly, I want to mention AB 45, the Treasurer's Loan Repayment Program. The Treasurer's Office has developed regs on that, and I believe they are close to finalizing and approving those regulations, and that ensures that the Nevada Health Service Corps is now fully funded. So, wanted to address a little bit of the needs, and by far the biggest need that we have is workforce. You heard Mr. Kelly's comments in public comment. And I think the way I look at it, last session was a really good start in addressing workforce. So we had the loan repayment bill, AB 45. In addition to that, we had AB 37, which created behavioral health workforce development centers. We had Senate Bill 289, which ensured protections against violence for healthcare employees and volunteers. We had Senate Bill 350, which implemented some much needed updates regarding GME and residency programs. We had Senate Bill 375 that Mr. Kelly mentioned regarding the allocation for those nursing programs. Senate Bill 117 made various changes for community health workers. AB 401 revised the nursing school faculty ratios. And AB 443 opened up the Millennium Scholarship to be able to include more nursing programs in that. And I think all of those are a wonderful start. Chair Dignate, you started off your comments today by specifically requesting that we bring forward solutions. And I took that to heart, and I wish I could say that we had a silver bullet to fix our workforce issues in the state of Nevada. But the reality is that there isn't one. We've all heard that saying, death by 1,000 paper cuts. And so I think we need life by 1,000 Band-Aids when it comes to workforce in the state. And I think we just listed off about 7 or 8 bills. I think that's a really good start. Really encourage the committee to build upon that in this next session. Some of the bills that didn't pass last session that could help and that we are in strong support of, Assemblyman Gray mentioned earlier the social work licensure compact. Arguably the more needy one, although the social work compact is very needed, is that nurse licensure compact, AB 108. And I know that's a hot topic. It's been discussed in a lot of sessions, but we would sure love to see that brought back and be able to be implemented into law this session. Additionally, Senate Bill 369, Senator Titus had that bill last session, which I thought brought about some very innovative ways to fund residency programs in the state. Would love to see more solutions around that. And lastly, AB 460 was a bill regarding nursing pools in the state. There's some very interesting technological solutions brought by companies like NERSA and others. They operate very similar to Lyft and Uber and some of these applications, where now they are able to, these companies sign up licensed nurses in the state, and they are able to partner with hospitals and list available shifts. And nurses can go on that app and they can look at what shifts are available to them and sign up and go over to XYZ hospital and work a shift on Wednesday and go over on Friday and pick up a different shift at ABC hospital. So some of those are technological solutions are in existence, but I think some of the regs currently in existence and some of the law around those nursing pools needs to be adjusted in order to bring about those solutions for the state. And that brings me to my conceptual policy proposal number 1 that the committee has. And Director Whitley kind of stole my thunder on it, which is great because we talked a lot about the nursing apprenticeship program. The nursing apprenticeship program in the state has been, in my mind, a phenomenal success, and would really love to see ways that it could be continued. Since March of 2022, more than 670 nursing students have been nurse apprentices in the state, and that's over 44 different nonprofit and critical access hospitals and skilled nursing facilities in the state. Additionally, the program has supported the direct hiring of more than 165 nurses upon their graduation from Nevada nursing programs. The program supports salary reimbursement for the nurse apprentice's time working in facilities, a salary stipend for the required supervising nurse, travel reimbursement for nurse apprentices willing to work in a facility more than 50 miles away, which obviously really helps and encourages those nursing students to be out in rural Nevada. And lastly, a retention bonus for the full-time employment of the nurse apprentice. So as Director Whitley stated, it was off to a little bit of a slow start. Now it's catching fire. I think word of mouth is very important. These facilities are talking a lot about the successes of this program. And so it would be a real shame as the ARPA dollars expire for this program to expire as well. So my first request would be for the committee to help us work on that and see what kind of budgetary support we could get for this program moving into the next biennium. Another area of need that I wanted to highlight is our conceptual policy proposal number 2 here. Currently, Nevada Medicaid does not cover surgical implants separately from the service, with the exception of cochlear implants and long-acting reversible contraceptives. So one Nevada critical access hospital is losing an average of $10,000 per surgical case for many of them are orthopedic surgeries. And I've got some more data, and I can submit all of this to the committee as we look at this. We look forward to working with Medicaid throughout this interim, but we would love to see some budgetary authority for Nevada Medicaid to cover the cost of these devices separately from the cost of the service. Lastly, I wanted to get into a little bit, just highlight for the committee that a lot of the infrastructure in the state of Nevada is aging when it comes to our critical access hospitals. We have 3 of our critical access hospitals. Senator Titus, I know you're very familiar with one of them that was originally built in the 1960s and the 1970s. These buildings have a lot of challenges, as many of you know, with asbestos, with size, with many of them being grandfathered into older codes. They have difficulties with and high costs in compliance with standard items like the ADA. They have even more challenges when it comes to being innovative or advancing technology with fiber optics. And so currently there's just not many resources available to support any of those types of large-scale infrastructure projects beyond limited USDA loan funding. So this is just an idea I'm kicking around. We have In Florida, I believe in their last legislative session, they passed a new capital improvement fund for rural hospitals. And so I don't have a proposal for you on what that might look like for the state of Nevada, but I think it's an interesting concept that is worthy of exploring. So these are some of the things that we've talked about, and I look forward to being here with you throughout the interim and working together on finding some of these innovative solutions. With that, I'd stand for questions.
Thank you so much. Committee members, are there any questions at this time? Blake, really quickly, just the fund that you mentioned at the end that Florida passed, do you happen to know any more specifics on it? Like how much money was allocated to it? Is it just for infrastructure improvements? Is it for other rural health facilities, or is it just critical access hospitals? Like, can you explain, I mean, as much as you can? I know that you alluded to it, but.
No, Senator, I really don't have a lot of details on it, but I will be happy to pull all of that and provide that to the committee.
Thank you, sir. Any questions here? Anyone in Northern Nevada?
Mr. Chair?
Please proceed.
Thank you. So we heard earlier today, and I know you were in the audience, Blaine, to hear this regarding Medicaid going to MCOs for the rural hospitals too. It's one thing that we have, in my time, pushed back from, that because we were a fee-for-service, basically cost to help keep those rural hospitals open. They said in their testimony that they've reached out to the rural hospitals, and I'm just wondering what the Rural Hospital Association, where are you as a group with that decision by the state and possible negative impacts or positive impacts
Sure.
either way?
Yeah, thank you for that question, Senator. Again, Blaine Osborne for the record. I want to start off by saying first, I sincerely appreciate the partnership that we, the rural hospitals, have with Nevada Medicaid. I think that relationship and that partnership is stronger than I've ever seen it. With that being said, they mentioned the road trip they conducted with rural hospitals in the fall, and I was a part of that, went to every one of those stops with Nevada Medicaid, and actually we had representatives from every division within DHHS as part of that trip, which was a phenomenal experience for those folks. One, for the hospitals to get access to the deputy administrators and administrators for each of those divisions, but also for those administrators and deputy admins to get out into our rural communities to see the hospitals and see what those communities look like. So I really appreciate Director Willey's support for that. We have always had kind of a reserved attitude or unenthusiastic approach to the expansion of managed care in the state. I feel very good now that with some of the language changes we've included in Senate Bill 241, some of these other pieces of legislation, that Nevada Medicaid has what they need in order to implement what they call state-directed payments. And so our understanding of state-directed payments is in essence, some of these rates that we've established for our critical access hospitals and rural health clinics are going to be the floors for where the managed care contracts will start with the rural hospitals. So with that, and that has really always been our big concern is, critical access hospitals get paid cost for a reason. That's in order to keep those hospitals in those communities. And so as long as those managed care plans are paying those rural hospitals correctly, then we feel very comfortable in supporting the expansion.
Thank you for that, and a follow-up, if I might, Mr. Chair.
Please proceed.
Thank you. So with that, and so they've agreed to do certain things when you made that tour, and thank you for participating in that, and it sounds like you're going to make the best of things. It looks like it's going to happen. Is there some quick checks and balances? These things move so slow, and I worry that if it's not sustainable, how quickly will we be able to, you as a group, be able to come back to us and let us know that, wow, we're losing money more than they are losing money, so that we don't lose these hospitals with this change. I just want to make sure that it may be a success. But if it's not, are these contracts written for a year with reevaluation every 3 months? Or how quickly will we be able to decide if it hasn't been a good decision?
Those are all wonderful questions, Senator. Again, Blaine Osborne for the record. These are all things we're thinking about, but right now, Nevada Medicaid hasn't released the RFP for those managed care organizations to even apply for the next cycle, that next 4-year cycle of managed care. And so I expect that RFP is actually going to be released probably sometime in the fall of this year or early next year. And with that, we're hoping that a lot of those things will be stipulated in the RFP and in the responses from some of those managed care organizations that end up applying. But I feel comfortable that we're going to be a part of that process and that we're going to be monitoring that very closely, and we'll be able to report back to this committee and to the full legislature how that implementation is going.
Great, thank you for that answer. 4-year cycles just are a big concern. Thank you. Thank you, Mr. Chair.
Thank you so much. Any other further questions from the committee members at this time? Seeing none, we'll go ahead and close these items. Just for the committee members to know, so in some of the now that, as you may have noticed, we are diving deeper into the access to healthcare conversation. We started these two presentations are going to connect us into the March meeting where we are going to spend the full day talking about access to healthcare. I have requested the groups that come before us to present policy proposals, and so at the end of the Access to Healthcare Day, we can deliberate them more into detail and try to discuss what they could look like if they were formed into a BDR. So let's go ahead into our last presentation item for today. We are now going to go into Agenda Item 9, an overview of rural tribal healthcare in Nevada, the challenges, equity issues, and policy considerations. And for this, we have Ms. Wilson, who is the Director of Tribal Health Center at the Reno Sparks Indian Colony. So please begin when you are ready.
Waklisi, Tusigama Diksha, Tu Sisunwi. Greetings and good day to everybody in attendance. Chairman Donante, Vice Chair, and members of the Joint Interim Committee, I want to thank you for allowing me to present to you today. My name is Angie Wilson, and I'm an enrolled member of the Pitt River Tribe of Northern California and a Klamath and Modoc descendant of the Klamath tribes of Southern Oregon. I serve as the Health Director for the Reno Sparks Indian Colony. In addition to my directorship, I also serve on the National CMS Tribal Technical Advisory Group for the Phoenix Area Indian Health Services on behalf of the Arizona, Utah, and Nevada tribes, and it's an honor to be here today. I'd like to start the presentation by describing the special federal trust responsibility and the legal obligations for Indian healthcare, just to kind of educate people about the tribal healthcare delivery system. There are treaties between the United States of America and our tribal nations that provide the original legal foundation of the federal government's obligation to provide health care for American Indians and Alaska Natives. And this is known as the trust responsibility. You'll hear me refer to that often in this presentation. Congress has defined this relationship in repeated case law, in statutes, and in executive orders as a unique political relationship, the only one of its kind. The modern authorization for the provision of healthcare services to American Indians and Alaska Natives is known as the Indian Healthcare Improvement Act, and the primary authorization to pay for federal services for general welfare remains to this day to be the Snyder Act. And just to show you a little bit about what our Indian healthcare delivery system looks like, it's covered in these three initials: the Indian Health, Tribal Health, or Urban Indian programs. So the Indian Health Services is an operating division of the United States Department of Health and Human Services. It provides culturally appropriate care to our American Indians and Alaska Natives across the nation. And again, we usually refer to it as ITU, Indian Health, Tribal, or Urban. The Indian Self-Determination and Education Assistance Act of 1975 then provided tribes the option of managing our own tribal health care delivery systems in contracting or compacting with the Indian Health Services. So in our state, this is what it looks like. We have 2 facilities that are directly operated by the Indian Health Service. We have one urban Indian program, that's Nevada Urban Indians, and we have 12 tribal health programs throughout the state, and you can see those listed here from Battle Mountain all the way to Yerington, which a lot of you are representatives. These tribes are in your particular areas. I want to cover just a little bit about what we're up against in Indian country, but before I start to go through a few of these disparities, I really want to say that it's important to note key historical factors that greatly impact the health outcomes of our American Indian people. The history of this nation is outlined in the development of federal Indian policy, all of which have played a key role in the impact to our people. And that's everything from coexistence to moving into the Indian removal and reservations era of the 1800s, to the allotment and forced assimilation era in the late 1800s to 1932, to the Indian Reorganization Act that lasted through 1945, to the urban termination era that lasted through 1960, and then where we are here today, known as self-determination. The removal, and one of the things I want to talk about just a moment so you can understand the impact to some of these outcomes, is during the Indian removal and the forced assimilation area, the removal from indigenous lands had a great impact on our Indian people. The forced assimilation into boarding school era resulted in the loss of language, culture, and traditional practices, traditional family units, loss of gathering indigenous foods and hunting, loss of traditional medicine and ceremony, and of course, we call that today historical trauma. One thing I'd want to mention is I'm not talking about hundreds and hundreds of years ago. I'm talking about this happened in my grandpa's era, my mom's era, my aunties and uncles' era. So in relation to that, I just really want to premise this before I cover some of the disparities, because all of this impacts where we are today, including the outcome of diabetes, alcoholism, suicide, and other risk factors in our communities. So I'm not going to go through all, but I'll cover some of these. I left the information for you, and I appreciate especially those of you with a healthcare background and clinicians, because you'll understand why this is so important to us. When I go through the disparities, these are coming from the Office of Minority Health on a national level, and they're compared to non-Hispanic whites, okay? So our American Indians and Alaska Natives have almost twice the infant mortality rate. Our infants are 2.7 times more likely to die from accidental deaths and 50% more likely to die from complications related to low birth weight. Our American Indian mothers are almost 3 times more likely to receive late or no prenatal care at all. Our American Indian adolescents are 30% more likely, and our adults are 50% more likely to be obese. Our adults are 3 times more likely to be diagnosed with diabetes and 2.3 times more likely to die from diabetes. We're twice as likely to be diagnosed with end-stage renal disease. There's some comparisons to heart disease and cancer, and I'm going to move on to the next slide. In 2019, chronic liver disease was the 4th leading cause of death for all American Indians and Alaska Natives, and the 2nd leading cause of death for our American Indian men aged 35 to 44. In 2018, our American Indian people were 1.6 times more likely to be diagnosed with chronic liver disease. American Indian women are 2.2 times as likely to be diagnosed with chronic liver disease and 4.8 times more likely to die from chronic liver disease. And the overall death rate for our Indians is also almost 4 times higher than that of the non-Hispanic white population. In 2019, suicide was the 2nd leading cause of death for our American Indians and Alaska Natives between the age of 10 to 34. In 2019, adolescent American Indian females aged 15 to 19 had a death rate that was 5 times higher than non-Hispanic whites. I'm sorry. And in 2018, our males, 15 to 24, had a death rate that was twice that of non-Hispanic whites. According to the CDC, in 2021, we had 1,358 American Indians die to the opiate overdose, the highest rate of any racial or ethnic group across the nation. And I know we've talked about some of that here today in the presentations that you've heard earlier. But the next statistic is overwhelming. Violent deaths, unintentional injuries, homicide, and suicide account for 75% of mortality in the second decade of our American Indian Alaska Native lives. So one thing I want you to understand, and I apologize, sometimes going through these are tough. There's a misperception that American Indians and Alaska Natives just get complete free health care and the tribes get all this federal funding. And I can tell you there's nothing further from the truth. There's a federal trust responsibility of the United States government to provide health care to American Indians, yet we have the highest health disparities of any other ethnic populations. And this is what funding looks like in our world. The Indian Health Services funding per capita spending is 50% of the next nearest federal health program expenditure. And you can see that outcome there. 2020 Medicare spending per enrollee, the veterans per enrollee, Medicare, the national health expenditure per capita, and then where we fall in the Indian Health Services. So I want to talk a little bit about the Federal Medical Administrative Percentage, FMAP, as it contributes to the opportunity to strengthen the government-to-government relationships between our state and our tribes. In 1976, the Indian Healthcare Improvement Act amended the Social Security Act to permit reimbursement by Medicare and Medicaid for services provided to American Indians through Indian Health Service or tribal health facilities. And these protections were further augmented in Section 5006 of the American Recovery and Reinvestment Act of 2009. When Congress authorized 100% FMAP, it did so because, quote, the federal government has trust obligations to provide services to Indians. It has not been a state responsibility. So in the next slide, I want to show you what that looks like for our state. The very first example is an American Indian Alaska Native Medicaid beneficiary that comes to our clinic. Our clinics are able to bill at the all-inclusive rate, which is a rate that's established in the Federal Register every year. And for 2024, that rate is $719. The tribes get to bill up to 5 Medicaid encounters per day if it's medically indicated. And the state gets 100% FMAP return, meaning that at the end of the day, there's zero cost to the state budget. When we refer a patient out to a specialty care provider and for additional services, and I think I heard you talk about that today, like we can see them in our clinics, but getting them out to specialty is really difficult. But when we do send an American Indian out to specialty care that has Medicaid and they see that Medicaid provider, the state does not get 100% FMAP on that. There is a cost of care for that particular service. And on the average, it's 68% FMAP. However, in 2016, CMS released the State Health Official Notice allowing expanded 100% FMAP to states for any referrals to or through Indian Health or Tribal Health clinics. So I want to show you what that would look like. We have two ways that we're able to do this. The expansion of FMAP to the state is controlled by the tribes. The state cannot mandate the tribes to do it. They cannot mandate it from Medicaid providers. It has to be at the discretion of the tribe. So the tribes can do a straight written care coordination agreement. And that's the next example where we would send somebody out to the Medicaid provider. The Medicaid provider sees our patient and bills their rate, and we have the written care coordination agreement with them. They can then bill the state, and the state can now get 100% reimbursement on that cost of care. But in that example, there's no benefit to the outside provider because they're not getting paid anymore. There's no additional access to care. It's going to be just as difficult for our Indian people to get into specialty care. The only winner in this situation is the state getting 100% FMAP. The other option is that tribes have the ability to negotiate a written care coordination agreement where I can go out to a Medicaid provider, offer a written care coordination agreement, and I can negotiate to pay that Medicaid provider a rate higher than what Medicaid can pay. So for an example, here I used a rate that would be the Medicaid rate plus 40%. So that outside provider would now get paid from the tribal clinics at $147, so that provider is happy that they're getting more money. It creates better access for our Indian people to be able to get into specialty care. But what happens is once they send those notes to us, we then get to turn around and bill the state our all-inclusive rate, the $719, and the state gets 100% of those costs back to its state budget. So in that particular option, this is a win-win for the outside provider, for the state budget, for clinics to be able to offset the disparities in our federal funding to better meet the needs of our American Indian Alaska Native patients so they can have hopefully better outcomes than some of the things we've just reviewed here shortly, just prior to this. So in doing that, before I give some suggestions, and I'll try to be mindful of the time, I just wanted to discuss a couple of items before I go into some potential things to think about as you go into your session, is to recognize that our tribes and tribal programs have the knowledge, expertise, and authority to design and deliver services in ways that are best suited for our tribal communities. And we do that by building on cultural strengths and traditions in the way that we provide care. To also understand that effective efforts for health equity in Indian country must approach health equity through the lens of tribal sovereignty, the government-to-government relationships like we're having here today, and also the federal trust responsibility. And it must conceptualize the work around and understanding of American Indians and Alaska Natives as a group with a unique political status, not as a racial minority. So with that being said, I'm just going to share a couple of things for you to consider. One of those is tribal Medicaid determination. I think we heard from the Medicaid department, from the Department of Health, Welfare and Supportive Services on getting people signed up for Medicaid, keeping them signed up. I could tell you right now, every single tribal clinic in this state works very hard to get our patients signed up for Medicaid and keep them on Medicaid. It's the only access that we have to bring in revenue into our clinics. It's the only access we have to deter the cost for American Indians. But we do the heavy lift because American Indians will just come to the clinic whether they have insurance or not to be seen. So we have to do a lot there. And what we're asking is there has to be a pathway to allow tribal benefit coordinators access to go through the Medicaid Academy, which we've already accomplished, but giving our tribes the ability to do on-site Medicaid determinations. You heard earlier from Duis that they do outreach, but what's really happening in our tribal communities is there's not enough outreach workers. So what we're hearing is we don't have anybody to send to you. That is huge for us in a state that we have 17 counties, 3 which are rural, and 11 frontier, which most of these tribal clinics reside in. We can be the assistance there for our Indian people. It's a big issue for us in Indian country, and it certainly impacts the state budget. Also, another is I have already requested through the Division of Healthcare Finance and Policy to consider a state plan amendment to expand tribal Medicaid reimbursement for pharmaceuticals. One additional thing I would really like to point out to this committee, if I could ask for anything, if I showed you how tribes control expanding FMAP to the state to look at reinvesting some of the 100% FMAP savings back into our tribal communities, because that's gathered based on American Indian Alaska Native Medicaid beneficiaries. And if we can work together in our tribes to extend FMAP to the state, to and through our clinics, you've seen some of the disparities that we're up against in regards to federal funding and what our outcomes can be. We can have great collaboration between our state and our tribes to be a win-win for all of us. And the supplemental documentation that I provided to you all, I gave you an example how the state of Oregon passed a House bill to do just that and then reinvest savings of 100% FMAP into the Oregon tribes. The other is tribal Medicaid administrative activities, looking at ways to partner with tribes to develop a pathway for tribes to be able to claim reimbursement of our Medicaid administrative activities. The state gets payment from CMS to not only run IHS, to run the Medicaid program, but to also operate it. But the tribes are doing a lot of the heavy work. And so I provided examples with other states in California and Alaska, where their tribes are doing outreach and education, helping people sign up for Medicaid, doing program planning for Medicaid beneficiaries, in which those recipients, those tribes, are able to claim for those costs back to the state. So we're looking for a pathway for that. Also, to just generally look at any state funding that comes through, maybe developing pathways to strengthen the government-to-government relationship instead of having tribes have to compete with outside agencies for any funding that comes through. And then last but not least is to look at culturally based practices, and that's that work that we can do on our end and accepting those culturally based practices into our system. One last issue I'll leave you with that I believe can be a great bill for you to consider is to expand the Silver State Health Insurance Exchange Board of Directors to add a permanent tribal representative to this seat to this board. And I think that I really want you to understand that the Affordable Care Act has been enacted now for over a decade, and every single provision for American Indians and Alaska Natives that are included in this law, tribal sponsorship, 0 to limited cost sharing provisions, open continuous enrollment, aggregate billing for tribes, so that makes it easier for us to be able to purchase insurance for our uninsured, and us not having to contract with the QHP to be able to get paid. None of it has been implemented for a decade. And I will just say this, we have had to do the heavy lift to educate the Silver State Health Board Exchange, the Nevada Health Link leadership, and the Department of Insurance every single step of the way. But I don't want to lose sight of the hard work that Russell Cook with the Nevada Health Link, since his leadership, has taken on this and really championed this through for us. So we have a good working relationship with the Nevada Health Link, but it shouldn't take a decade. And I think that if we had a permanent tribal representative on that seat, we wouldn't have run into these issues because we know our healthcare delivery systems. This is important to us. All of these years, we could have been purchasing insurance for our Indian people and closing the loop, but we've had no pathway to get there. So that would be the ask that we have. I know that we're short on time, so I just want to leave you with some other just general larger ideas that maybe we can return and continue to have dialogue on ways to strengthen our tribal public health capacity and infrastructure. I want to thank especially Chairman Donate for asking for this presentation on tribal health care. I really just want to say thank you to the Joint Interim Committee of just opening up the dialogue. I think it's important. I think this is a historic moment, and I'm very proud to be here.
Thank you so much, Ms. Wilson. No, don't worry about it. Is this your first time presenting to the legislature? Just by a quick
Here,
question.
yes, but not my first time presenting. Last week, I actually gave testimony Washington, D.C. to the Senate Committee on Indian Affairs for a bipartisan bill sponsored by Catherine Cortez Masto and Mark Wayne Mullins from Oklahoma. I think I get emotional as a tribal health director. I've been in tribal health administration for 30 years, and when you stop and you just take a look at the outcomes of Indian people, you can't help but to feel it right here.
Yeah, well, I just want to, before we go into questions, I know that many of us are probably eager to dive into your policy considerations, et cetera. This was a phenomenal presentation. I've had groups ask us for presentations, et cetera, but you laid it out perfectly in a good example of explaining the context, explaining the relationships with how the state can help your organization, how we can address the issues, and then you gave us exactly a lot of pages of documents, which is a good thing because now we can actually have robust conversations with you. So I want to allow my committee members to ask any questions if they have any here in Southern Nevada. Anyone in rural, or not rural, in Carson City, North Nevada? Is that Senator Titus?
Thank you, Mr. Chair. And first, thank you putting your energy, your time, and your dedication to your whole career and the folks around you and the people you represent. And thank you for doing that. Obviously, it's emotional. You own it. It's important. I live that also. I have many tribal members, currently have a number of them in long-term care, taking care of some of these things that, and when I'm taking care of people younger than me in long-term care, it just makes my heart break. And so I appreciate your passion for that. I have a couple questions, actually. I think, are there 47 distinct tribes? How many distinct tribes have been recognized in Nevada?
28.
28, okay. Now, the question is how, with that 28, do they each need to negotiate? Would each tribe have to do their own negotiation when it comes to the Medicaid and FMAP? Like you representing the, you're in Reno Sparks, is that correct? So you would do yours, but can that be replicated, or does each tribe need to do their own? And do they even have capacity to do that?
Yes. So what happens is the Nevada Tribal Health Directors really work closely together. And actually, the Reno Sparks Indian Colony, our tribal health clinic, is the very first clinic to actually transition into this particular model. We went through a state plan amendment to have a new designation known as a Tribal Medicaid FQHC status, which would allow us to extend the FMAP to the state. So what we've done is we've worked closely with the Department of Healthcare Finance and Policy to get all of the fee schedules for every single provider, and we've worked with our tribal leadership to develop mechanisms for what our rates could be. And we're working closely with the other Nevada tribes so that when we go out to negotiate, we're having the same mechanisms that we can use. So Reno Sparks is the first to go through the process, and a lot of times our tribes work together to see who goes through that process first, what's working. Because the one thing we don't want to do is to say Reno Sparks can offer this rate, and then a tribe over here will say, well, we're going to offer a little bit different rate, and then that same provider hold out. So the nice thing about doing this is that in option 2, where we can go out and negotiate rates with the outside providers, the really great thing here is that when we're billing our encounter rate, the $719, we can assume those costs. So we want to do it as consistently as we can. But at the end of the day, the tribes are sovereign, and they do have the right to negotiate whatever rates they choose to. Although I think all of us at tribal health, in our tribal health capacities, feel the need to be as consistent as we can.
Right, thank you for that, because I was concerned about the basically price setting or rate setting, because you're all literally 28 sovereign nations. And if you collaborate to a certain degree, where does that get into trouble with federal regulations and laws, et cetera, et cetera? So at least you are communicating with each other about the application process, because not all 28 tribes would have the resources to do that. So you can share that, but that rate setting may have some issues there.
I think actually the tribes are afforded full capacity. So through CMS and through the new designation, we can determine any capacity. A tribe could also determine not to negotiate a rate and still expand 100% FMAP to the state on option 1. However, it would only be at that provider's rate. Right. So again, it doesn't open the door for access to care. And we talked a little bit about that in some of the other presentations today. Is it's really difficult when you're a primary care provider to try to get somebody into neurology or dermatology, or let alone into women's health care. And so, that's part of the challenge that we have. So what we're hoping to do is have capacity to be able to overcome those challenges that end up being a win for that provider, the state, and our tribes.
And, thank you for that. And on one other note, if I might, Mr. Chair, continue, the concern, it's tremendous, the loss of young lives through in the tribal nation, and the figures that you gave on the percent of deaths in that group, and the number one cause of death is dramatic, especially recently. More information come out about the loss of women, especially young women, disappearing, death, et cetera. As a body, when you went to Washington or wherever, how do you see us helping? I mean, money's all money. Money may or may not be out there, but how can we as a state help you address that? Is there, at some other conversation. Can you come up with some suggestions? Mental health is issue everywhere. Drug addiction's an issue everywhere. But those particular statistics for the group that you represent are incredibly dramatic. And it has to be more than just access to health care.
We hosted Secretary Becerra at my clinic a couple weeks ago and had the exact same conversations about the need in our tribal communities and what we're up against. And I think every single one of us sitting in this room that happen to be American Indian have all had somebody missing or murdered in our families. I know I have. When I talk a little bit about the chronic, liver disease, my sixth extended family member has just succumbed to cirrhosis, all of which were under 34 years old, and the most recent being 28. So it's challenging. I think that one of the things, if I could say anything, is having these conversations. This is the first time that I'm aware of that the tribes have been able to present to the Joint Interim Committee on issues, and I think that the number one thing is to really open up these conversations. I think that sometimes when we don't understand each other, we have our own healthcare delivery system, and I know it can be confusing, but if we can see how we can partner, which is win-win opportunities for us to see how we might be able to get our hands around some of these issues, I think the number one thing is what we're doing here, right here today. I do think that I've been listening intently to the presentations and the dialogue in this entire meeting from the time I got here to now. When I hear pharmacists talking about access, especially for the opioid issue, and looking at how that affects our rural communities, it's huge. So the fact that you're doing the work that you're doing to see how we might be able to get our hands around this in this state, I can't tell you the significant impact to our tribal communities in you already doing that work at looking what we can do. I would say there's other issues that I can sit here and go on all day long about, mobile clinics and access to care and how do we help, the workforce issues that we have in this state are severe for our tribal clinics. And so I think that opening this dialogue, inviting us to come back, doing work sessions, whatever we can do to better understand where you may be able to help us and what we can ask for. I think looking at things that help to decrease the barriers for tribes, because we're all on this, when I look at it, I can see that we all are on the same team, we just don't know how. And I think that if we were able to sit down and look at how can we truly address these barriers and be innovative in this state to really close the gaps is huge. So I would just encourage us to continue dialogue here. And I'm 100% willing to come anytime and meet with any of you on opportunities that we can be very innovative in this state to support our First Nation people.
Thank you for that, and thank you, Mr. Chair, for the questions.
Thank you so much. Any questions in Carson City? I can't see the camera, so is there anyone else up there? Mr. Gray, Assemblyman Gray, please proceed.
Thank you, Chairman. Just a couple of quick questions. One, where would you talked about reinvesting the money back into the community. What would you see that looking like? Back into the clinic, programs, outreach? That's the first question. Second one, with the opioids, do you guys have as easy access to Narcan? I mean, is it readily available in the community?
Yes. We do have access to Narcan. I think it's been a big issue for us and making sure that we have immediate access. Also to harm reduction tools like fentanyl test strips and those types of things. We are actually looking at putting kiosks where people can have immediate access to Narcan or fentanyl test strips and those types of things, whether the clinic's open or not. And putting those kiosks all throughout the tribal community so people would have immediate access. So we're looking at that. I would also say that when we look at reinvestment of the savings of 100% FMAP, there's a million ways that we can use that. If I looked at, and if you saw some of the disparities we have in our healthcare funding to meet the need and what our disparities actually look like, there's a million different ways that we can use the reinvestment of those funds, additional healthcare providers, more access. We just purchased mobile clinics, a mobile dental and medical clinic, being able to staff those. I think that there's, so many innovative ways to reinvest. I know that for the Oregon tribes, for part of that savings, will divvy that up with the tribes based on their patient populations and allow the tribes the allowance to design programs that best meet the needs in their tribal communities for the patients that they're seeing and what they can do. I think should always go back into healthcare. I mean, these are dollars that are derived from Medicare and Medicaid expenditures, so they should go back into the healthcare delivery system. But I would just encourage continued open dialogue on ways we might be able to do that.
Thank you so much. Assemblyman Gray, did you have any other further questions?
Nope, she answered it great. Thanks.
Thank you so much. Anyone else in Northern Nevada? Assemblyman Nguyen.
Thank you, Chair. Again, I really appreciate your level of expertise. It's hard to not get emotional in your presentation as well. So I just want to say I'm absorbing everything you're saying. As an immigrant to this country and learning how everything works, I still have a hard time truly represent the community that I grew up with, as well as millions of immigrants in this country in terms of the culturally competence and peace. So I'm very, very, I think that turned on a couple of light bulbs here in terms of the culturally based practices. And in terms of the tribal relationship, when you work with the tribes across the country in terms of making sure that all of you are in sync in these culturally based practices model, I'm wondering, and maybe I'm asking this question as a learning opportunity for the communities that I represent, the immigrant community that are always underserved, and then also from a culturally competency level, we're still fighting to this day in terms of having folks understanding, that complexity that that we grew up with, or we came from another part of the world. How does that work in terms of the culturally based practices? That would be, of course, obvious and solidified in terms of the tribes internally, right? So what if you have young people or, folks who go to school outside of tribes, right? Or you have folks who maybe not living in, tribal area, but they live in, the suburban area outside of the tribes. How would you kind of ensure that these culturally based practices are being communicated, to the non-tribal communities?
I think a couple of things. One, I think for our Indian folks that move away, let's say, and they go to more urban Indian settings, that's why the urban Indian healthcare part of the ITU system is so important, so that we can stay that connectivity to tribal healthcare needs. I would say when it comes to the non-Indian population, sometimes it's really kind of looking at how do we get to, when we talk about health equity, right? If we just look at health equity across the board, what is that? Healing from our past. Well, how can we heal from how can anybody tell us how to heal from our past if they don't understand who we are, what our traditions are, what our values are, right? So I feel like when we look at alcohol and drug treatment, that's a great example. SAPTA is going to want to make sure that we're following evidence-based practices. But in American Indian communities, one of the beautiful things that I love about our culture is there's specific practices and cultural ways that we follow that require you to be sober, that require you, if you go into the sweat lodge, you cannot be using. They help you on that path to wellness in a culturally appropriate way that go hand in hand with evidence-based practices for alcohol and drug treatment programs. That's just to give an example. So when we work with other entities, right, treatment programs or what have you, I think that's always really important that we have that connection. We do that right now with our folks that are incarcerated in jail, have our particular clinicians be able to reach out to the jail to offer, particular services or support. And I think any opportunity that we can continue to do that is really meaningful, especially in our communities. Like I said to you, some of the history of our nation wasn't all that long ago. I mean, when I look at my grandpa, he's in the 1930s. All of this was happening during that time. So it's a lot. It's a fresh wound that we're still dealing with today. So I think we have to look at ways, and I would encourage that we're open to that no matter what ethnicity, to be able to respect that of who we are in our healing pathway moving forward.
And thank you for that lessons. And I encouraged you to continue working with not just this joint committee, but the multicultural communities in Nevada and across the country in terms of share some of your best practices on how we can collectively help all of our communities to be able to truly be seen. Because, like you said, the immigrant community as well, for like the Vietnamese community, this is only the first time that they have a voice from the immigrant community from Asia, and we're still changing some of those narrative, and we want to be able to learn from you all as well of how we can work together. So I would seek out to your guidance offline and be able to see how we can effectively, not just in the interim, but in the years to come, lift us all up. So thank you again for all your work, and I applaud your commitment to just the state of health for all Nevadans.
Thank you.
Thank you so much. Any further questions? I do have just a couple of them, Ms. Wilson, for you. So there's some that are contextual to your presentation and then some that aren't. But let's talk about some of the policy recommendations you presented. Part of me just wants to put them all in one BDR and see how far they go. But I want to make sure that we do our due diligence, because I want to make sure that we actually make some progress. Let's talk first about administration. So in one of the documents that you submitted from the California State Tribal Medical Administrative Activities, they talk about, and excuse me as I'm going through this, they talk about the Tribal MAA program, which is created to address a number of concerns relatively to our Native American tribes, et cetera. And then it talks about, later in the document, there's discussion about the California Rural Indian Health Board that was founded in the 1960s to help tribal governments in California to serve as central coordinating points for planning and development. I think that's kind of what you've alluded to. Do you feel, in just of your, I guess, in your position and your experience and some of the coordination you do with other folks or other tribes in other states, is there a gap in authority or coordinating entities that perhaps we don't have in our state in terms of infrastructure that you would like to see fit? For example, like the MAA program in California, I don't know if Oregon has a different authority, perhaps programming that you wish the state had that we're not there yet. I mean, I guess that would be the first question.
Sure, I would say yes. I think that one of the challenges we have is understanding what is eligible for tribes to be able to look at it within the law. So for the California Rural Indian Health Board, they're a consortium of tribes, and they act as the health board for a number of rural tribes in California. California has 110 federally recognized tribes, and the California Rural Indian Health Board serves a portion of those tribes in technical assistance and support. In California, the state of California developed a pathway for tribes to be able to claim reimbursement for Medicaid administrative activities, and they did that by opening up a local governmental agency option, which in fact the California Rural Indian Health Board stepped up to the plate and said, we'll do it, so that all tribes would submit their claims to the California Rural Indian Health Board. The Rural Indian Health Board would make sure those claims were consistent and appropriate, and then they would send it off to the state of California for reimbursement. The state would then reimburse the California Rural Indian Health Board, and the California Rural Indian Health Board would then reimburse the tribe. So they were the medium in between the state and the tribes. But it provided a pathway for tribes to be able to claim for necessary reimbursement for those services. And so I think here in our state, we don't have a mechanism for that. So I think just identifying these are options that tribes should be able to apply for or get reimbursement for. We're doing the work that the state gets paid to do on their end for Medicaid administrative activities. So how could we tap into that as tribes? And I think that the first part of that is just having the dialogue that it's possible. And the second part may be, how do we find the pathway to get there? And so, that might take some collaborative effort. It may take some reinvestment of 100% FMAP savings to develop what that looks like, or the agency that could, step up to the plate to do those reimbursements, or, additional staffing at the state to support that effort. So we just think that we have to, like I said, we have to be somewhat innovative. We don't have, an agency like the California Rural Indian Health Board here in this state.
Thank you. So I'm assuming the answer is there interest to pursuing that? Do you think that that could help with your effort, well, your notes earlier about recaptured funds, making sure they're being reinvested in the coordination? Is there an interest to pursuing that policy
Yes.
option or
Absolutely.
Okay.
I think that's a huge issue for us because, like I said, we could be a benefit to the state. We heard earlier from Medicaid's Department of Welfare and Supportive Services on the outreach, but I can tell you in tribal communities, we don't get the state workers out there right now because they don't have the staffing for it. With a lot of our tribal clinics in very rural areas, it makes it even harder. My clinic's right here in Reno, and they can't get somebody out here on a regular routine because they don't have the staffing. Imagine if I were in Walker River or Ely, which makes it even that much more difficult. So this is where I think the tribes could be a benefit, a partner with the state in closing the gap on that. Especially that the state gets 100% FMAP for American Indians and Alaska Natives seen in our clinics.
No, I completely agree, and I appreciate your comments. And I think that could, if we do it right, then that sets us up pretty much with the Oregon proposal that you had. There's a number of initiatives that I think our state could be replicating in terms of family wellness projects, developing child care centers, right, to explore the health disparities that you presented earlier. But we don't have the mechanism to that. So I'm glad that is something that we should consider. I want to talk about COVID-19. I think that there's always a discussion of where we went wrong, right? Which is okay. I mean, nothing ever goes as planned, especially when the unplanned happens. But I want to have your perspective as to how do you feel in terms of your personal perspective of how the coordination occurred between our tribal communities and healthcare during the COVID-19 pandemic, and what do you think should be prioritized in terms of reforming the system? We talked about the oversight now that we could potentially explore, but what do you think we should explore, at least with regards to how we have emergency preparedness and response and just the coordination of care?
Well, I think a couple of things, and I just want to back up and just kind of give a perspective here. I think the beautiful thing about our tribes is at the end of the day, our commitment is to Indian people. And for us, it doesn't matter who's in charge. We need to have the dialogue. When Medicaid expanded, Governor Sandoval was in office, and we worked closely with him on looking at the potential of opening Medicaid here. When COVID hit, Governor Sisolak was in the seat of the governorship, and at that point, I think we were all hit. Everybody, just out of the whole world at that point. The challenging part for us, I will just say this. I feel like we have a good partnership with the state of Nevada in a lot of ways. Governor Sisolak really did bring the tribes together to talk about what are the needs, the current needs right now. How can we help? Tribes were forthcoming in that. The Indian Health Services on the federal level was involved. But I will tell you, we were really taxed thin when it came to anything along epidemiology or assistance along that way. We partnered with Northern Nevada Public Health, and it really tried to work with them to collaborate vaccines, testing, you name it, and really trying to get our hands around it. I can tell you that the Reno-Sparks Indian Colony lost a significant amount of members of its tribe that succumbed to COVID-19, which was devastating for the tribe, but we weren't the only tribe to experience that. All of the Nevada tribes were as a result of that. I will tell you that that's a direct impact to the high prevalence of chronic disease and risk factors in our Indian communities. And when it had to deal with COVID-19 across this nation, American Indians and Alaska Natives had the highest rates of hospitalization than any other ethnic population across the entire nation. So again, I think that speaks to the prevalence of chronic disease and risk factors in American Indian communities and the lack of resources to get our hands around healthcare services in our tribal communities because of the lack of fiscal resources. I think that one of the things I would say is there's a lot of lessons learned all the way across the board. I don't think it was easy for any of us, but I would just say that I think that we can come together and say what were the disparities and how do we start building on them? How do we start partnering for better outcomes for data? What about tribal data when it comes to some of the mechanisms? We heard our partners give a presentation on the SHIP, right, earlier. I can tell you I've been working with Northern Nevada's team that did their community needs assessment, and we don't have good data outcomes for American Indians and Alaska Natives. So I think that when we look at epidemiology or surveillance, especially when it comes to things like a pandemic, we need a better partnership where the tribes meet the state halfway, and we look at ways that we can develop opportunities to strengthen what that looks like here. But I will say this, it's not just the pandemic. You know, when I look at the environmental impact, Renal Sparks has been hit with the AQI issues when we've had past fires. We've had Pyramid Lake be impacted when it comes to flooding and the destruction of even roads out there where people couldn't even get access in or out. We've had the Washoe tribe be prevalent to mudslides right there in the Carson colony, or fires right up to their tribal reservations and their tribal communities. And so I think across the board, there's always improvement that could be needed on building capacity to support our tribes at the local level in regards to community education and first responders training, in addition to the impact of public health initiatives across the board. So there's always dialogue, and I think we should always sit down and figure out how we can get through that. But I think there's a lot of opportunities for improvement and vast opportunities for sharing things that have worked well with us.
Thank you so much. Any last minute questions or comments before we close on this presentation item? Seeing none, Ms. Wilson, we greatly appreciated your time. I'm sure we'll be reaching out, and this might not be the last time that you hear from us during this interim. So I greatly appreciate your time and for your presentation.
Thank you. And Chair, I just want to say one thing
Sure.
before I go. I really want to just say thank you so much to the Joint Interim Committee. This is history in the making. You should be very proud, and I know we are in Indian country, to even have this dialogue. Genuinely, Sepkecha, thank you so much.
Thank you so much as well. All right, we'll go ahead and close this agenda item, and we'll move on to the next one, which is our last and final agenda item before public comment, which is a discussion of topics related to the Health and Human Services Committee to be considered for future committee meetings. This is just an open dialogue. If there are any further last comments that folks would like to have in discussions for the following interim committees, issues to explore. I know Assemblyman Gray mentioned the compact of social workers, so we'll have that discussion when we get to the behavioral health day, but this is the moment if anyone else has any other comments or requests. Assemblyman Hibbets.
Thank you, Chair. I would like to see if we might be able to get some information on the growing mental health crisis in our state, specifically the state-run mental health hospital in Lakes Crossing. And the reason I'm asking is because there's a massive backlog moving criminal defendants that have been deemed incompetent or awaiting competency tests. Once a judge orders them to the hospital, they have approximately 30 days, I believe it is. And the state hospital is taking 90 to 180 days to get them there. So our state is suing itself to try to solve this problem. And I'm hoping that somehow we might be able to come up with something that would assist that hospital in expanding their capability so that we don't have this backlog again. But I'd like to hear more from them if we might be able to do that.
Sounds great. We'll make sure to list that down. We do have behavioral health will be a considerable amount of time during this committee. We are probably going to do it closer to May, June, and it'll be split in half. We'll have one day dedicated to children's behavioral health and a separate day for adult mental health, just because it's a lot. But we'll make sure to take that as a note. Any other discussion items or anything down here? Anyone in Northern Nevada? Assemblyman Gray?
Thank you, Senator. As long as we're going to be talking about the social worker compact, I'd also like to talk about the nursing compact again as well. That's really something we should be exploring.
Thank you so much, sir. Any other one else? Assemblyman Nguyen.
No, that was just pointing out that Assemblyman Gray was raising his hand, but thank you, Chair.
Sounds good. Anyone else before we close out this agenda item? I think we're good. All right, moving on to the last
Mr. Chair,
agenda
sorry.
item. Senator Titus.
Thank you. Just kind of an overview per, really on a discussion that you and I had is that I appreciate you putting this organization of this committee together, the fact that you're focusing on things that we can accomplish. This is a big world that we're looking at and lots of needs. But one of the things that I brought up to you when we had our conversation was that I believe this committee gets 10 BDRs. And many times, and I've served on this committee many times, we put out all the time and effort on the BDRs, but we only get one or two passed. And so, and I know that there's no guarantee that we'll get more passed this next time around, but I like the concept that we're focusing on things that we may really be able to achieve. So we may not be able to solve all the problems, but we should try to solve the ones we can. And so breaking it down and on the presentations you had today and moving forward, I truly appreciate that approach and want to thank you.
Thank you so much, Senator Titus. I couldn't agree more. I think what you'll see it more when we get to the March meetings, that after the end of each day, now that we've broken down into those different subject items, that at the end of these committee meetings, we will have the ability to deliberate and discuss policy options. We have several of them already through this committee meeting, and so we'll get to the point where we can start identifying what these BDRs will come in. And as I mentioned earlier, our goal is to make sure that all of them get passed bipartisan and fully supportive so that they can make their way all the way to the end in 2025, and that is something that I'm committed to. So, all right, if there's anything else, I think we will go ahead and move on to public comment. Is there anyone else that would like to, at this time, we'll go ahead and open the public comment period. It is limited to 2 minutes each, so for folks that would like to come forward, please come forward now. We'll begin here in Southern Nevada. Please proceed.
Thank you so much, Senator Dunyate and the members of the Interim Health and Human Services Committee. My name's Ken Kunke with the Nevada Pharmacy Alliance. We have two other policies that we're working on this session that I'd like to bring up and basically offer our support to you if it's something that you're interested in. The first one is prescription benefit managers. Ever since AB 440 died in last session, I've been reading things daily about how these entities work and why we're not passing laws here in Nevada about these prescription benefit managers. And what I found is that they control all the data. So basically, they can come to you guys and insurance companies and patients and say, hey, we're saving the actual healthcare system money. But if they're truly doing that, why aren't they releasing their data? Why isn't that data available? So what I've seen is there are 16 policies that are tracked in other states, nationally, and some states have passed all 16 of those policies, but unfortunately Nevada hasn't passed any of those. So I've been reading those policies and I have a list of people that deal with PBM reform on a regular basis, or West Virginia and Florida just passed comprehensive reform. California, it's in their session right now. Indiana has a bill in their session right now that would make that data available to insurance companies and the state. So it might be something that we want to look at here in Nevada. The second issue is not dealing with PBMs or actually, right now, a lot of the payment that pharmacists get are for dispensing product. Well, this is actually, we have scope to do things, but we're not able to bill for our clinical services for a lot of things. So if you take the example, if a pharmacist was to get hired at a primary care clinic, If the doctor met with that patient for 15 or 20 minutes or whatever the meeting was, and they discovered that that patient was on a lot of medicines and they might be having a lot of side effects or they're not controlled well, a pharmacist is able to meet, like the patient would transfer to another office or whatever and meet with the pharmacist. Right now that pharmacist cannot bill for that service. So there's no sustainable way for that pharmacist to work inside that clinic. So SB 201 was brought up last session, and I think we just started the education on that way too late. And we would like to bring that back again this session and actually find a way for patients to be able to see a pharmacist inside a clinic. And you keep talking the access to healthcare. We really feel like this would benefit our state. And we've seen in the last 2 years, 7 states pass this type of reform. So thank you so much. I'm here. If you have any questions for me, please reach out.
Thank you so much. Anyone else in Southern Nevada offering public comment? Anyone in Northern Nevada? BPS, anyone virtually?
Thank you, Chair. The public line is open and working, and there are no callers at this time.
Thank you so much. Just a few housekeeping items before we close out. Our next meeting is on March 11th, 2024. We have opened the link for people to submit policy recommendations. It is available on the Nevada Legislature's website through the Joint Interim HHS Committee, so folks now can start the process of submitting items early. We are doing it earlier than we did last time during the interim, just for the ability for folks to be interacted with us. And then hopefully we can provide some good policy recommendations towards the end. So that concludes the work of today, and I thank everyone for coming out, and of course to our committee members for their thoughts and recommendations. So meeting is now officially adjourned.